Hello friends, welcome back. This is Dr. Pritesh Singh, Surgery Faculty with PrepLadder. So let's start the rapid revision. First, we are going to start the chapter breast, and in that we are going to discuss the causes of nipple discharge. So see, what are the causes of nipple discharge and what are the types? Nipple discharge. Okay. So first, what are the causes of bloody nipple discharge? Bloody nipple discharge. The most common cause is duct papilloma. And what are the other causes? Carcinoma and ductictasia. So most common causes duct papilloma. Other causes are carcinoma and ductictasia. Ductictasia. Okay. Out of this, what is the most common cause? The most common cause of bloody nipple discharge is duct papilloma. After that, serous nipple discharge. What is the most common cause of serous nipple discharge? It's the fibrocystic disease. The second is serous nipple discharge. And the most common cause of serous nipple discharge is fibrocystic disease. Okay. What are the other causes? So it can be caused by carcinoma and it can be caused by ductictasia. Ductictasia. Now see, greenish, blackish, grumous, pultaceous. This kind of discharge is seen in ductictasia. So what are the causes of this greenish, blackish, grumous, pultaceous discharge? And that's ductictasia. It's the ductictasia. So now look at the questions. First question, that what is the most common cause of bloody nipple discharge? And that is duct papilloma. What is the most common cause of serous nipple discharge? That is fibrocystic disease. And any kind of nipple discharge is possible in ductictasia. Any kind of nipple discharge is possible in ductictasia. Now see the questions related to treatment. In duct papilloma, since it's benign condition, we are going to excise the involved duct only, and that's known as microdocectomy. So what's the treatment of duct papilloma? We go for microdocectomy. That is the excision of involved duct only. And in cases of ductictasia, we go for conical excision of involved duct. And what's the name of that operation? That's known as Hadfield's operation. So this is Hadfield's operation for ductictasia. Now we are going to discuss the risk factors for breast cancer. Let me tell you one basic principle. If we are going to compare adenocarcinoma from squamous cell carcinoma, you are going to notice that adenocarcinomas are generally more common in high socioeconomic status and squamous cell carcinomas are more common in low socioeconomic status. Why? Because generally for adenocarcinoma, high fat diet and obesity, both of these are risk factors. So if you see the example, carcinoma breast, carcinoma prostate, adenocarcinoma of esophagus, all these are seen in high socioeconomic status. And if you see carcinoma cervix, carcinoma penis and squamous cell carcinoma of esophagus, all of these are more common in low socioeconomic status. So whenever you are going to remember the risk factors of adenocarcinoma, have one thing in your mind, that generally these are more common in high socioeconomic status and squamous cell carcinomas more common in low socioeconomic status. So in breast cancer, you will see that the risk factors will be revolving around high socioeconomic status. So see the list of risk factor: advancing age, origin from Western countries, high socioeconomic status, and you must be knowing in females of high socioeconomic status there is alcohol intake also, high fat diet, and because of this high fat diet there is obesity. You know that state of hyperestrogenemia is a risk factor for breast cancer. Hyperestrogenemia means early menarche, late menopause, nulliparity, late first full-term pregnancy. So these are the states of hyperestrogenemia, and state of hyperestrogenemia is a risk factor for carcinoma breast. What are the other risk factors? Positive family history, especially maternal side. So personal history of malignancies. So which malignancies are seen in females? Endometrial carcinoma, ovarian cancer, and carcinoma cervix. So out of endometrial, ovarian, and cervical carcinoma, there are two which are adenocarcinomas, and there is one which is squamous cell carcinoma. So carcinoma cervix is squamous cell carcinoma, so it is more common in low socioeconomic status. So which two will increase the risk of CA breast? Endometrial cancer and ovarian cancer. So personal history of malignancy, which one? First is endometrial cancer and second is ovarian cancer. Okay. Now, genetic mutations. You know, BRCA1 and BRCA2 mutations. Both of these mutations are going to increase the risk of carcinoma breast in both males and females. BRCA1 and BRCA2, both of these are going to increase the risk of CA breast in both males and females. But if you see BRCA1, this one is responsible for breast cancer mainly in females, and BRCA2, this is responsible for breast cancer mainly in males. Okay, how to remember? Ladies first. So BRCA1 mainly in females, BRCA2 mainly in males. Hormone replacement therapy is another risk factor, and if patient has received radiotherapy, how much is the dose? If it is therapeutic dose, that is also a risk factor. So these are the risk factors for CA breast. Let me tell you, OCPs and smoking are not the significant risk factors. I'm repeating, OCPs and smoking are not the significant risk factor for CA breast, and you know, long history of breastfeeding is protective for breast cancer. See, long duration of breastfeeding is protective for breast cancer. Before discussing breast cancer, let's first discuss ductal carcinoma in situ and lobular carcinoma in situ. So you know, ductal carcinoma in situ, it is having high risk for progression to invasive ductal cancer. If we see the breast of both males and females, ducts are present. Ducts are present in the breasts of both males and females. That's why invasive ductal cancer is seen in both males and females. But in females, lobules are present. Lobules are present only in females. So lobular carcinoma is seen only in females. Okay. So ductal carcinoma in situ, it is having high risk of progression to invasive ductal cancer. Invasive ductal cancer, and we discussed that invasive ductal cancer, it is seen in both males and females because both males and female breast have ducts. Lobular carcinoma is exclusively seen in females. On the basis of nuclear grade and necrosis, on the basis of nuclear grade and necrosis, this ductal carcinoma in situ is divided into low grade and high grade. So cribriform papillary and micropapillary, these are included in low grade DCIS. Solid and comedocarcinoma, these are included in high grade DCIS. Now coming to the investigations, you know that in ductal carcinoma in situ there is presence of microcalcification. So question is asked that what is the most sensitive investigation for diagnosis of microcalcification? That is mammography. And the most sensitive investigation for diagnosis of DCIS, that is MRI. So two important questions: most sensitive investigation for diagnosis of ductal carcinoma in situ. So MRI is more sensitive. And if it is specifically asked that most sensitive investigation for diagnosis of microcalcification in DCIS, then answer will become mammography. So what's the answer? Mammography. Okay, and on mammography you can see microcalcification better, right? So you have to read the question carefully. Now coming to the treatment. So what's the treatment for non-palpable DCIS? So here we are going to perform the excision by needle localization with specimen mammography. Okay, so here excision by needle localization. Okay, and after excision we have to go for specimen mammography with specimen mammography. Okay, and if patient is having low grade DCIS, for that lumpectomy is sufficient. But if there is ductal carcinoma in situ with limited disease, in this case along with lumpectomy we have to give radiotherapy. So for low grade DCIS, lumpectomy only, and if there is DCIS with limited disease, we go for lumpectomy and we give radiotherapy. So this is how we manage DCIS. Now see, lobular carcinoma in situ. This lobular carcinoma in situ arises from terminal duct lobular units. Terminal duct lobular units, only females have lobules, that's why lobular carcinoma is only seen in females. So important questions, it arises from terminal duct lobular units, and another important point that it is only seen in females. What is the other property of lobular carcinoma in situ? That it is multicentric and bilateral. Since it is multicentric and bilateral, that's why it is going to increase the risk of bilateral breast cancer. So important property, it is multicentric and bilateral, that's why there is increased risk of bilateral breast cancer. It means it's a marker for increased risk of bilateral breast cancer. It's a marker for increased risk of bilateral breast cancer. In pathology also questions are asked related to lobular carcinoma in situ. In LCIS there is cytoplasmic mucoid globules, and what is the histologic hallmark? The histologic hallmark is Indian file pattern. This is the Indian file pattern. So what's the clinical presentation? Generally, these patients have lump at the time of presentation, and these lumps are having ill-defined margins. Ill-defined margins. How we are going to make the diagnosis? So suppose we go for mammography. In DCIS, there is presence of microcalcification. In LCIS, there is presence of calcification in the surrounding, not in tumor per se, and that's known as neighborhood calcification. So patients present with lump, and these lumps have ill-defined margins, and how we are going to make the diagnosis? There is presence of neighborhood calcification. You have to remember this term, neighborhood calcification. What are the treatment options? So you know that in LCIS there is increased risk of bilateral breast cancers. So either we go for observation and follow-up, or we go for chemo prevention. Which drugs are given for chemo prevention? We give tamoxifen and raloxifene. Tamoxifen and raloxifene for chemo prevention, or we can go for prophylactic bilateral mastectomy. So this is how we manage LCIS. Now in detail we are going to discuss the breast cancer. First see the important one-liner questions. So first question, what is the most common histological type? We discussed it is adenocarcinoma. Second question, what is the most common histological subtype? We discussed it is invasive ductal cancer. This is invasive ductal cancer. Okay. Now, what is the least common type? Least common type, that is papillary. Now, how to remember? See, the most common type of thyroid malignancy is papillary, and the least common type of breast cancer is papillary. So here you have to remember the least common type of breast cancer, it's papillary. This is papillary. What is the most malignant type of breast cancer? inflammatory breast cancer, and since it's most malignant, it is having worse prognosis. So most malignant type having worse prognosis, and that is inflammatory breast cancer. In NEET PG, this question was asked that least malignant type of breast cancer means having best prognosis, and here it's the tubular. It's the tubular. Now see the questions related to site of breast cancer. So breast cancer is more common in left breast as compared to right. First question. Now in left breast or in the breast, it is most common in which quadrant? So it is the upper outer quadrant. Why upper outer quadrant is the most common site? Because of presence of maximum breast tissue. So what is the least common site? And this is the lower inner quadrant. Why? Because there is least amount of breast tissue. So most common site is upper outer quadrant, least common site is lower inner quadrant. Now see the questions related to route of spread. If we are going to see the adenocarcinoma's most common route of spread is lymphatic, and in sarcomas most common route of spread is hematogenous. Adenocarcinoma most common route of spread lymphatic, in sarcomas it is hematogenous. So in CA breast, what is the most common route of spread? It is lymphatic. Most common route of spread, that is lymphatic. But the most common site of metastasis in CA breast is bone. Which bone? Lumbar vertebra, followed by femur, followed by thoracic vertebra. So another question, most common site of metastasis in CA breast, it is bones. Okay, and which bones? Is the lumbar vertebra, followed by femur, followed by thoracic vertebra. So how to remember? LFT, lumbar vertebra, followed by femur, followed by thoracic vertebra. In bones, what kind of secondaries are seen? So in bones, we see both osteolytic secondaries as well as osteoblastic secondaries. Both osteolytic as well as osteoblastic secondaries. Which one is more common? Osteolytic. Osteolytic secondaries are more common. So question is asked indirectly, what's the most common primary for both osteolytic and osteoblastic secondaries in the females? And the most common primary is CA breast. But because of bone metastasis, death doesn't occur usually. So what's the most common cause of death in CA breast? It is malignant pleural effusion. Another important question. So most common cause of death in CA breast, and this is malignant pleural effusion. Is the malignant pleural effusion. Okay, before discussing signs and symptoms, first see the pathway of spread of breast cancer. So what happens here? Breast cancer via posterior intercostal vein involves the Batson plexus. Via Batson plexus, it can go to lumbar vertebra and it can reach this dural venous sinuses. Via dural venous sinuses, leptomeninges can be involved and brain can be involved. So this is the pathway of spread. It's very, very important. Have a look. So here you can see breast cancer cells. These breast cancer cells are going to invade which vein? Posterior intercostal vein. You have to remember this was asked in NEET. Posterior intercostal vein. Via this posterior intercostal vein, there is involvement of Batson plexus. Batson plexus. Okay, and after involvement of Batson plexus, there can be involvement of what? Either lumbar vertebra or there can be involvement of dural venous sinuses. Dural venous sinuses. From dural venous sinuses, there can be involvement of leptomeninges. Leptomeninges. So what is the most common primary for leptomeningeal metastasis? CA breast. And from leptomeninges, there can be involvement of brain. So there is brain metastasis. You can't believe that from this flow chart, 6 questions were asked. Question first, breast cancer cells are going to invade which vein? Posterior intercostal vein. Via posterior intercostal vein, Batson plexus is involved. And for involvement of lumbar vertebra, yes, the malignant cells are going to involve Batson plexus. What is the most common site of metastasis? Lumbar vertebra. For leptomeningeal metastasis, which sinuses are involved? Dural venous sinuses. And we discussed what's the most common primary for leptomeningeal metastasis. And the most common primary for leptomeningeal metastasis, it is CA breast. And what's the most common primary for brain metastasis? You know, it is CA lung followed by CA breast. So most common primary for brain metastasis, that is carcinoma lung followed by carcinoma breast. It's very important. Now see the clinical features. What is the most common presentation of CA breast? Obviously it's the lump. So most common presentation of CA breast is lump. What are the other findings seen in advanced cases? Now imagine a female patient who is educated and she noticed the lump, she came to you. The female noticed the lump, she came to you. Some females who are from rural area, not very educated, not having access to health services, what they are going to notice the lump, but they are not coming to you. So what will happen over a period of time? The size of lump keeps on increasing. So when size keeps on increasing, you are going to notice that there is architectural distortion. Shape is going to change. Then there is asymmetry if you are going to compare both breast. After that, these tumors are going to involve breast skin. It is going to involve nipple and it is going to involve chest wall. So whenever there is involvement of breast skin, there is skin fixity. If there is involvement of chest wall, the tumor is fixed to chest wall. And whenever there is involvement of nipple, it can lead to nipple retraction, nipple deviation, nipple ulceration. So because of involvement of nipple, there is nipple retraction. There can be nipple deviation. There can be nipple ulceration. Now look at both nipples and tell me what is the diagnosis here. So here you can see that there is nipple retraction on the left side. Some patients at the time of presentation have metastasis. So these patients can have backache because of metastasis to vertebra. There can be headache because of involvement of brain. There can be dyspnea because there is pleural effusion or involvement of lung. There can be jaundice because of involvement of liver and anorexia and weight loss. So these are the signs and symptoms of metastasis. There are certain important signs which are asked almost every year and in the form of image based question. So see this picture and tell me what's the diagnosis. First thing, you can notice that there is nipple retraction. What is the finding? Nipple retraction. And the second thing you are going to notice what? That there is pudiorange. This question was asked in AIIMS that what is the most conspicuous sign of breast cancer? Is the pudiorange. Is the pudiorange. Is the most conspicuous sign of breast cancer. And what's the cause? See, this is the lymphatics. So by tumor, there is permeation. So there is lymphatic permeation by tumor cells. Tumor cells are going to obstruct the lymphatics. There is cutaneous edema, and that cutaneous edema is known as pudiorange. In this image, you can see that there is skin depression like this. So when there is skin depression, this is known as what? Dimpling. And here you can see wrinkles or skin fold. This is known as puckering. So skin depression, this is dimpling, and these kind of wrinkles or skin fold, this is known as puckering. Puckering. Both dimpling as well as puckering are because of involvement of a ligament. Which ligament? Ligament of Cooper. So there is involvement of ligament of Cooper, and this involvement leads to what? Dimpling and puckering. So this is cancer in cuirass. What's the name of this condition? Cancer in cuirass. What is the problem in cancer in cuirass? You can see that there is presence of multiple nodules and ulceration. And in cancer in cuirass, there is involvement of breast skin and chest wall. So what is the finding? Presence of multiple nodules and ulceration in the breast skin, and there is involvement of breast skin and chest wall. So there is dimpling, skin fold, puckering, and multiple nodules and ulcers. This is known as cancer in cuirass. So when patients of breast cancer are coming to us, we are going to take the history first, perform the examination. So we perform clinical assessment. After that, we send the patient for radiological investigation or imaging, in which we perform mammography or ultrasound, and we send the patient for tissue sampling that includes FNAC and biopsy. So this is known as triple assessment. What are the components of triple assessment? So first is clinical, which include signs and symptoms. So it's clinical, include signs and symptoms. Second is imaging, radiological investigations. So we perform mammography or ultrasound. So this is mammography or ultrasound. And the third is tissue sampling. And in tissue sampling, what we perform FNAC or biopsy. So this is triple assessment. So what's the positive predictive value of triple assessment? Frequently asked question, it is 99.9%. Triple assessment is having positive predictive value of 99.9%. Now see the important points related to investigations. First question, what is the first investigation done in suspected case of breast cancer? And that's mammography. First investigation done in a suspected case of breast cancer, that's mammography. What is the investigation of choice for diagnosis of breast cancer? Means you have to confirm the diagnosis, and it's the biopsy. Clear? Sometimes in exam you will get the option true cut biopsy. So biopsy is also known as true cut biopsy, core cut biopsy, needle biopsy. So this can be true cut, core cut, or needle biopsy. All these are same. So this is investigation of choice for diagnosis of breast cancer. So let's first discuss mammography. Very, very important. Every year there is one question from mammography. First question, that mammography is investigation of choice for screening of breast cancer. Investigation of choice for screening of breast cancer. At what age screening should be started? And this is the latest update. Screening should be started at 45 years of age, and you are going to start it at 45. After that, annual mammography. So started at 45 years of age. After that, annual mammography is recommended. Special type of X-ray is used in mammography. What's the name? It's known as Brehm straw lung. What's the special type of X-ray used? It's the Brehm straw lung X-ray. Another question frequently asked, how much is the radiation exposure in mammography? It is 0.1 centigrade per study. How much is the radiation exposure? It's 0.1 centigrade per study. It means it's very low. So one mammography is equal to how many X-rays? This formula you have to remember. One mammography is equal to 4 chest X-ray. Means the dose in mammography is very, very low. It's not going to increase the risk of breast cancer. On the basis of mammography films, how you are going to differentiate benign lesions from malignant? So whenever you are looking at mammography film, first look at the nipple. Focus here. So if you look at nipple here, it's normal or retracted. So you're going to notice that it is retracted. Normal nipple should be like this. Then focus on breast skin. This is the breast skin. Third, focus on this opacity. Opacity is having regular margin or irregular margin? Irregular margin. Next, focus on presence of calcification, whether there is microcalcification or macrocalcification. Microcalcifications are seen in malignancy and macrocalcification is seen in benign disorder. You can see that this is pectoralis major muscle and this is the breast tissue. In between pectoralis major and breast tissue, this is the line. Can you see? So this space is known as retromammary space. What's the name? This is retromammary space. So what happens in malignancy, you are going to notice that the opacity is having irregular margin, there is nipple retraction, there is skin thickening, presence of microcalcification, obliteration of retromammary space. If you see the second mammography, see the nipple, it's normal, okay, and there is presence of what? Popcorn calcification. So this is macro calcification, and you know popcorn calcification is seen in fibroadenoma, which is a benign disorder. So this is how you can easily differentiate benign disorders from malignancy. So what are the differences between benign disorders and malignant? First see the edit kar lena. So what are the differences between benign disorders and malignant disorders? First you have to focus on opacity. So the opacity in benign disorder is regular, it is having smooth margin, homogeneous, low density. It means the density is comparable to breast tissue, and there is thin halo. In cases of malignancy, there is irregular margins, and you have to remember three words which are asked in exam. What kind of margin? Stellate margin. Remember these three words: stellate, spiculate margin, or comet tail margin. Stellate, spiculate, or comet tail margin. Obviously, malignant disorders, in malignancy on mammography, the opacity is heterogeneous, it is having high density, and there is wide halo. If you are talking about calcification, what kind of calcification is seen in benign disorders? It's macro calcification. It means what should be the size? More than 0.5 mm. In cases of malignancy, it's the microcalcification. And how much is the size here? Less than 0.5 mm. In benign disorders, associated changes of the breast are absent. But in malignancy, you will find that there is nipple retraction, there is skin thickening, there is obliteration of retromammary space. So, associated changes in the breast, these are generally absent in benign disorders. In malignancies, these associated changes are present. And what are those changes we discussed? There is nipple retraction, you can see there is skin thickening and obliteration of retromammary space. So all these are clearly visible on mammography films. Another question which is asked every year, either in surgery or in radiology, and that's BI-RADS. First, what's the full form of BI-RADS? It's Breast Imaging Reporting and Data System. Breast Imaging Reporting and Data System. See the various categories of BI-RADS and their description. Category 0. 0 means mammography is 0. It means there is incomplete assessment. And if there is incomplete assessment by mammography, additional imaging is required. So category 0. In this category, there is incomplete assessment. And if there is incomplete assessment, what? Additional imaging is required. Category 1. This is negative. And if mammography is negative, we ask the patient to come next year. It means what? Annual mammography is recommended. So here, it's negative. So annual mammography is recommended. Category 2, it's benign, and if it's benign, then also we have to advise that come next year, means annual mammography. So category 2, this is benign, and in this case also what? Annual mammography is recommended. Category 3, it's probably benign. You're not sure, but it's probably benign, so short-term follow-up is recommended. Category 3, that's probably benign. Okay, and here we advise short-term follow-up for category 3. Short-term follow-up. Category 4 is suspicious. If it is suspicious, we have to confirm by biopsy. So biopsy is recommended. Category 4, this is suspicious, and since it is suspicious, here biopsy is recommended. So category 4 is further divided into 4A, that is low suspicion, 4B, that is moderate suspicion, and 4C, that's high suspicion. So what's the further category? It is 4A, 4B, and 4C. Clear? 4A, that's low suspicion, 4B, that's moderate suspicion, and 4C, and that's high suspicion. Category 5 is highly suggestive of malignancy, and if it is category 5, intervention is recommended. So category 5, it's highly suggestive of malignancy, and in this particular category, intervention is recommended. So here intervention is recommended. And what's category 6? Category 6 is biopsy proven malignancy. So category 6, this is biopsy proven malignancy. These are frequently asked nowadays. Okay, they give you one situation and they ask you what is this category, or they will ask you in this particular category what's the description of the lesion. There is a latest pattern of asking risk of malignancy in various categories. So what's the risk of malignancy? For category 0, it's not applicable because there is incomplete assessment. If we see category 1 and category 2, how much is the risk of malignancy? 0%. In category 3, which is probably benign, here how much is the risk of malignancy? More than 0 to 2%. Now see the risk of malignancy in various subtypes of 4. In 4A, it's more than 2 to 10%. And in 4B, it's more than 10 to 50%. And in 4C, it is more than 50 to 95%. More than 50 to 95%. How much is the risk of malignancy in category 5? It's more than 95%. This is the latest trend. So you have to remember the risk of malignancy is also in various categories. So this is BI-RADS, very, very important. So we discussed investigation of choice for screening of breast cancer is mammography. So what's the role of MRI in breast cancer? MRI is investigation of choice for screening of breast cancer in high risk females. And what's the definition of high risk female? Imagine Angelina Jolie. It means if the female is having positive family history, if the female is having positive family history, or the patient is having genetic mutations, which one? BRCA mutation. Angelina Jolie was having both. Her aunt was having breast cancer and she was having BRCA1 mutation. So MRI is investigation of choice for screening of breast cancer in high risk females. We use breast implant, and whenever there is implant related complications, what is the investigation of choice? MRI. Sometimes patient is having a benign lesion and we have to differentiate it from scar. So if we want to differentiate scar from benign lesion, investigation of choice is MRI. Now see the twist in the question. If the question is asked, investigation of choice to differentiate recurrence from scar, from fibrosis, from necrosis, then answer is PET scan. So what's the role of MRI? Investigation of choice for screening of high risk females is the investigation of choice for diagnosis of implant related complications, and it's the investigation of choice to differentiate scar from benign lesions. Now what's the role of ultrasound? See, if a young female whose age is less than 35 years came to you with lump, what is the first investigation done? Ultrasound. Why not mammography? Because in young females age less than 35 years, the breast is dense and glandular, it is going to decrease the sensitivity. So question related to ultrasound. ultrasound, it's the first investigation done in young females less than 35 years with, you have to remember, lump, with lump. Now, what's the role of PET scan in breast cancer? There is one common indication of PET scan in most of the malignancies. So whenever there is distant metastasis, we go for PET scan. So PET scan is the investigation of choice for diagnosis of distant metastasis. And second thing we discussed here, that whenever after surgery or whenever you are suspecting recurrence and you have to differentiate recurrence from scarring, fibrosis, necrosis, you go for PET. First is the investigation of choice for diagnosis of distant metastasis, and second is the investigation of choice to differentiate what? Scarring, fibrosis, necrosis from recurrence, okay. And if the question is asked that investigation of choice to differentiate scar from benign lesions, then answer is MRI. Investigation of choice for bone metastasis, so scan the bone, that's bone scan. So what's the role of bone scan? This is the investigation of choice for diagnosis of bone metastasis. So this is investigation of choice for diagnosis of bone metastasis, right? So these are the battery of investigations which are performed in CA breast. Two important questions. First, investigation done in a suspected case of breast cancer, mammography. And what is the investigation of choice for diagnosis of breast cancer? Biopsy, also known as true cut biopsy, core cut biopsy, needle biopsy. Now we are going to discuss breast conservation surgery. And you know, this breast conservation surgery, it is performed for early invasive breast cancer. What are the stages? In early invasive breast cancer, it is stage 1, stage 2A, stage 2B. What is done in breast conservation surgery? This is the breast and this is nipple and areola. If you are going to divide the breast into quadrants like this, imagine that there is a lump. If there is lump and we are going to excise the lump. So if there is lump, we are going to excise the lump. This is known as lumpectomy. So this excision, it's known as lumpectomy. If we are going to take 1 centimeter margin around the lump and we are going to excise it, this is known as wide local excision. So imagine this is the lump, okay, and I'm going to take margin of 1 centimeter around the lump and then I'm going to excise it. This is known as wide local excision. Third situation, if I'm going to excise the whole quadrant, this is known as quadrantectomy. So imagine a situation in which I'm going to excise this whole quadrant and this is known as quadrantectomy. Clear? So what are the three things we are performing? One is lumpectomy, excision of lump. With 1 centimeter margin, I'm going to excise the lump, that is wide local excision, and third is quadrantectomy. So three things. This is lumpectomy. This is wide local excision and this one is quadrantectomy. Okay. After breast conservation surgery, we have to give radiotherapy because there is increased risk of recurrence. It means one principle is clear, that any patient who is having contraindication of radiotherapy, that patient will be having contraindication for breast conservation surgery also. Like pregnancy is an absolute contraindication for radiotherapy, and that's why pregnancy is an absolute contraindication for breast conservation surgery also. So see the list of contraindications. See the absolute contraindications first. So we discussed pregnancy is an absolute contraindication. Whenever there is 2 or more than 2 tumors in different quadrants, 2 or more than 2 tumors are there in different quadrants, or there is diffuse malignant appearing microcalcifications. What kind of microcalcifications? diffuse malignant appearing microcalcifications. If there is persistently positive margins or patient already received therapeutic radiation means patient already received therapeutic dose of radiotherapy. If you repeat the dose, what will happen? There is increased risk of radiation induced malignancy. So these are absolute contraindications. See the relative contraindications. First, history of collagen vascular disease. Which diseases are included here? Scleroderma and active lupus erythematosus. Active lupus erythematosus. These are the two diseases which are included. If there are multiple tumors but the tumors are present in the same quadrant, or there is indeterminate calcification, means the kind of calcification is present but you don't know what kind of calcification is this, indeterminate calcification. Third is large tumor in small breast. Why? Because if there is large tumor in small breast, there is very little breast tissue which is present or which is conserved. Next is large tumor in small breast. It means after breast conservation surgery, there is very little amount of breast tissue left. Large pendulous breast. What's the problem? There is very difficult. Next is large pendulous breast. So what's the problem in large pendulous breast? It's difficult to give uniform dose of radiotherapy in large pendulous breast. And next is centrally located tumor, because in such tumors you have to excise nipple and areola and it's difficult to reconstruct the nipple and areola. So these are contraindications. And you know, in early invasive breast cancer, if there is contraindication for breast conservation surgery, so what should be done? Simple or total mastectomy. Now we are going to discuss breast reconstruction. There are three methods of breast reconstruction. First is autogenous, means patient's own tissues are used. Alloplastic, here we are using silicone implants. And in combined method, both autogenous and alloplastic things are used, right? So one by one we are going to discuss. First, autogenous. Most commonly used flap, that is tram flap, is the tram flap. Full form, transverse rectus abdominis muscle flap. Second is LD flap, that is latissimus dorsi flap. There is thoracoepigastric flap, lateral thigh flap, gluteal flap, and Rubens flap. This Rubens flap is based on deep circumflex iliac artery. It is based on deep circumflex iliac artery. So these are the flaps which are used. Most commonly used flap is tram flap. In alloplastic method, we are using silicone implants, and let me tell you, worldwide most commonly used method for both breast augmentation as well as breast reconstruction are silicone implants. So silicone implants are the most commonly used method for breast augmentation and breast reconstruction. So what kind of implants we are going to use? We are using silicone gel implants, we use silicone gel implants, and we use silicone implants with saline refill. Silicone implants with saline refill. Okay, and you know, whenever we are using implant and some kind of complication is going to occur, what is the investigation of choice for diagnosis of breast implant related complications? And we discussed investigation of choice for diagnosis of breast implant related complications is MRI. Combined methods. Imagine a female who is having large breast. So if you are using only tram flap or only implant, it is very difficult to restore the symmetry. So for females who are having large breast, we are using tram flap plus implant or LD flap plus implant. So for females with large breast, we are using tram flap plus implant or LD flap plus implant. Okay, so tram flap plus implant, LD flap plus implant. These are the methods of breast reconstruction. Now comes the important question. For breast reconstruction, what is the most commonly used flap and what is the best flap? The most commonly used flap we discussed is the tram flap. It's the tram flap. And what is the best flap? It is DIEP flap. So see why DIEP flap is best. Have a look. Now see this image. This is tram flap, transverse rectus abdominis muscle flap. So here you can see transverse rectus abdominis muscle flap has been taken, and it is based on inferior epigastric vessels. So this flap is based on inferior epigastric artery and inferior epigastric vein, and we are going to perform the anastomosis with internal mammary artery and internal mammary vein. So here you can see the anastomosis has been performed between internal mammary artery and inferior epigastric artery, internal mammary vein and inferior epigastric vein. Problem with this tram flap, the problem is that we are going to excise the muscle, and if you are going to excise the muscle, what's the problem? There is weakness, and because of this weakness there is hernia. So why tram flap is not best? Because there is weakness because of excision of muscle, and it can lead to hernia. If you see this DIEP flap, that is deep inferior epigastric artery perforator flap. So here it's a free flap based on deep inferior epigastric artery perforators, and what we are going to transplant in this case or use, here we are using only skin, fat and blood vessels. Means in this case the muscle is not excised, and if muscle is not excised, muscle stays in place, there is no muscle weakness, that's why there is no hernia. So most commonly used flap, tram flap, and the best flap is DIEP flap for the breast reconstruction. Before discussing the prognostic factors in breast cancer, see this statement: what is the most important prognostic factor in most of the malignancies? And that is stage. Why? Because it includes T and M, all three. There are two exceptions. First is Wilms tumor. What's the most important prognostic factor in Wilms tumor? It's histology followed by stage. And the second is soft tissue sarcoma. In soft tissue sarcoma, the most important prognostic factor is tumor grade. So what are the exceptions? So first is Wilms tumor. In Wilms tumor, it's histology followed by stage. You have to remember, this is very important question. Histology followed by stage, and the second is soft tissue sarcoma. In soft tissue sarcoma, the most important prognostic factor is it's the tumor grade. Okay, now see the prognostic factors in breast cancer. So we discussed what is the most important prognostic factor. It's the stage, and stage includes T and M. Imagine the question is single most important prognostic factor, means out of T and M, which one is most important in CA breast? It's the N, that is axillary lymph node status. So read the question carefully. Single most important prognostic factor, and it's the axillary lymph node status. Third situation, what is the most important prognostic factor in metastatic breast cancer? So when there is metastasis, already it's stage 4, and in metastasis we discussed that whether patient will respond to hormone therapy or not, it depends on hormone receptor status. So if it's positive, patient will respond. If it's negative, patient will not respond. So what's the most important prognostic factor in metastatic breast cancer? And that's hormone receptor status, or ER/PR status, estrogen progesterone receptor status. So these are the important questions related to prognostic factors in breast cancer. Another one-liner which is frequently asked, that's Nottingham Prognostic Index. So what is this Nottingham Prognostic Index? This formula is asked. NPI, Nottingham Prognostic Index, is equal to 0.2 into tumor size, 0.2 into tumor size plus lymph node stage plus tumor grade. Lymph node stage plus tumor grade. And why we calculate this Nottingham Prognostic Index? it's calculated to select patients for adjuvant treatment. Another important one-liner is Bloom-Richardson grading. What are the components of this Bloom-Richardson grading? Very easy to remember. The mnemonic is T and M. T means tubule formation, N means nuclear pleomorphism, and M means mitosis. If you have seen the papers of AIIMS and NEET from the last 3 years, there is one question which is frequently asked, that is Van Nuys prognostic index. We discussed that in patients of ductal carcinoma in situ, certain patients require radiotherapy. So this Van Nuys prognostic index, it is used for the patients of DCIS who don't require radiotherapy. The patients of DCIS who don't require radiotherapy. See the components. So how to remember the components? Mnemonic is microswag. So how to remember? Microswag for Van Nuys prognostic index. Micro means microcalcification. S, that is size of tumor. W, it means the width of margin. A is age of patient, and G, that's grade. It's very important, you have to remember. So it's microswag for Van Nuys prognostic index, microcalcification, size of tumor, width of margin, age, and grade of tumor. Another very important topic, that's sentinel lymph node biopsy. What is the definition of sentinel lymph node? So sentinel lymph node is the first lymph node which receives lymph directly from the tumor. Sentinel lymph node is first lymph node which receives lymph directly from the tumor. Who established the concept of sentinel lymph node biopsy? It was established by Cabana. In which particular malignancy? Carcinoma penis. So it was first described by Cabana in carcinoma penis. That's why sentinel lymph node biopsy in carcinoma penis is known as Cabana procedure. Sentinel lymph node biopsy in carcinoma penis, that's known as Cabana procedure. Okay. There is established role of sentinel lymph node biopsy. Previously, established role was for carcinoma breast, carcinoma penis, and malignant melanoma. 2 more malignancies have been added. One is head and neck malignancies and second is carcinoma vulva. So there is established role of sentinel lymph node biopsy in 5 malignancies: carcinoma breast, carcinoma penis, malignant melanoma. These were asked names. You have to remember head and neck malignancies and carcinoma vulva. Now coming to the breast, what is the indication of sentinel lymph node biopsy in CA breast? It is clinically node negative axilla. It means it is clinically non-palpable axillary lymph node. So what is the indication of sentinel lymph node biopsy in CA breast? Clinically non-palpable axillary lymph node. See the technique. So what are the techniques for sentinel lymph node biopsy? Here you can see we are injecting blue color dye. So this is blue dye technique. Okay. And second thing, you can see that radioactive substance is being injected. So this is radioactive colloid technique. So second is radioactive colloid technique. Okay. Questions: in blue dye technique, which dye is being injected? So this is 1% lymphazurine, also known as isosulfan blue. So we inject 1%. All these are questions. 1% lymphazurine. What's the other name? It is isosulfan blue. These are the dyes which are being injected in blue dye technique. And in radioactive colloid technique, we inject technetium-99 labeled sulfur. What? Technetium-99 labeled sulfur. We can perform both of these techniques separately or together. So whenever we are going to combine both of these techniques together, there is maximum accuracy of detection of sentinel lymph node. That's why generally blue dye technique and radioactive colloid technique, both of these are performed together. How? First, where you are supposed to inject the dye or radioactive substance. This was question which was asked in a latest exam. It is not injected in the nipple. Not in the nipple. It is injected around the nipple. First question, dye or radioactive substance is injected around the nipple, means in areola subcutaneously. So it is injected around nipple, means in areola subcutaneously, and around the tumor also. Clear? Here you can see when you inject the dye and radioactive substance, it will be going directly to the sentinel lymph node. How we detect the sentinel lymph node? You can see this is the gamma probe. So the lymph node which receives the radioactive substance, that will be having maximum radioactivity. So whenever you are putting that gamma probe, you are going to detect the maximum radioactivity. So the lymph node which is having maximum radioactivity, that is the sentinel lymph node. So you localize the lymph node, and then what we do, we excise it. And whenever we are going to excise it, obviously what will be the color? It's blue. So here you can see this blue colored sentinel lymph node, and this sentinel lymph node is sent for pathological examination. These were two image-based questions which were asked in AIIMS. Here you can see the surgeon is putting what? Gamma probe in axilla to detect the maximum radioactivity. Okay, and here you can see this bluish lymph node is being excised. So what is this procedure? This is sentinel lymph node biopsy. It's not necessary that there is only single sentinel lymph node. Let me tell you, in breast, generally, there is more than one sentinel lymph node. In breast, generally, there is more than one sentinel lymph node. So now coming to the question, what's the most common complication of sentinel lymph node biopsy? It's easy. If you inject dye beneath your skin, in tattoo shop you go and dye is being injected. So what happens? There is tattooing. So here also we are injecting dye. That's why the most common complication is the tattooing. Right? Whenever we are performing this sentinel lymph node biopsy, there is one nerve injured here. And what's that? Intercostobrachial nerve. You have to remember it's intercostobrachial nerve. So the most common complication of sentinel lymph node biopsy, tattooing, and the most commonly injured nerve is intercostobrachial nerve. What are the contraindications of sentinel lymph node biopsy? So if you remember indication, clinically node negative axilla. It means if there is palpable lymphadenopathy, it's contraindication. If patient has received chemotherapy, radiotherapy, or axillary surgery has been done, then sentinel lymph node biopsy is not useful. So if patient is having prior axillary surgery, chemotherapy, radiotherapy, these are also contraindication. And if there is multifocal breast cancer, this is also a contraindication. So these are the contraindications of sentinel lymph node biopsy. Next important topic is inflammatory breast cancer. And you know what's the other name of inflammatory breast cancer? It looks like mastitis or breast abscess. That's why it's known as mastitis carcinomatosa. So this is the breast cancer which looks like inflammatory disease. Which one? Mastitis. So the name is mastitis carcinomatosa. What's the stage? T4D. This T4D corresponds to which stage? Stage 3B. It means it is a locally advanced breast cancer. This malignancy behaves like a locally advanced breast cancer. And you know what's the treatment of locally advanced breast cancer? It's neoadjuvant chemotherapy plus MRM plus radiotherapy. Basic principle. Since inflammatory changes are there in the breast, so how much breast skin is involved by inflammatory changes? In the definition, you have to remember more than 33%. So more than 1/3 or 33% of breast skin is involved by inflammatory changes. So in the breast, what are the inflammatory changes which are seen? There is erythema, there is brani induration, and there is early onset of puty orange. So in this image, you can see The inflammatory changes are involving more than 1/3 of breast skin. There is erythema, there is induration, and there is early onset of peau d'orange. What's the cause of this early onset of peau d'orange? In this case, there is early lymphatic permeation by tumor cells. And if there is early lymphatic permeation by tumor cells, there is early lymph node metastasis, and there is early distant metastasis. So if there is early lymph node metastasis and distant metastasis, at the time of presentation, you can't believe that 75% patients have already lymph node enlargement, means lymph node metastasis, and 25% patients at the time of presentation, they have distant metastasis. One important point which you have to remember, that in inflammatory breast cancer and Paget's disease of nipple, presence of lump is not mandatory. Presence of lump is not mandatory for the diagnosis of inflammatory breast cancer and Paget's disease of nipple. So how we are going to make the diagnosis here? Here, the diagnosis is made by skin biopsy. It's by skin biopsy, and what you are going to find in skin biopsy, presence of tumor cells in the lymphatics. What's the treatment? We discussed it's a type of locally advanced breast cancer, so treatment is neoadjuvant chemotherapy plus MRM plus radiotherapy. And we discussed most malignant type of breast cancer, inflammatory breast cancer with worse prognosis, inflammatory breast cancer. So inflammatory breast cancer is most malignant breast cancer having worst prognosis. Breast cancer in pregnancy. So what's the incidence of breast cancer in pregnancy? It is 1 in 3,000 pregnancies. Breast cancer is the most common non-gynecological malignancy of pregnancy. Most common non-gynecological malignancy of pregnancy. Most of the things are not going to change in breast cancer. Means, what is the most common type of breast cancer? Invasive ductal cancer. So here also the most common type is invasive ductal cancer. This is the most common type. Second, what is the most common presentation of breast cancer? Lump. So here also the most common presentation is lump. But the problem, in pregnancy there are pregnancy induced changes in the breast. When patient is going to develop malignancy or breast cancer, patient is confused. Why? Because pregnancy induced changes in the breast are going to mask the signs and symptoms of breast cancer. So that's why, what's the problem? Though there is lump, there is delayed presentation. There is delayed presentation. And because of this delayed presentation, at the time of presentation, 75% patients have lymph node metastasis. This is one difference. Second difference, what's the first investigation done in a suspected case of breast cancer? Mammography. In pregnancy, we don't go for mammography because there is radiation exposure. So what's the first investigation done in a suspected case of breast cancer in pregnancy? So here, the first investigation, yes, it is ultrasound. It's not mammography, it's ultrasound. Investigation of choice for diagnosis, it remains same, and the investigation of choice for diagnosis, that's biopsy. Simple. Now coming to the treatment. It's easy. If a patient is having early invasive breast cancer, generally we go for breast conservation surgery plus sentinel lymph node biopsy plus radiotherapy. You know that pregnancy is an absolute contraindication for radiotherapy and breast conservation surgery. So in such patients, we go for simple mastectomy. So in patient with early invasive breast cancer, we go for simple mastectomy. Simple mastectomy. Okay, one principle. Second, if patient is having locally advanced breast cancer, what's the treatment? In patients of locally advanced breast cancer, the treatment is neoadjuvant chemotherapy plus MRM plus radiotherapy. Problem, you know that maximum risk of abortions occur in the first trimester and organogenesis occurs in the first trimester. So if organogenesis occurs in the first trimester, you cannot give chemotherapy in first trimester. Maximum risk of abortion is in the first trimester, so you cannot give general anesthesia in first trimester because it increases the risk of abortions. So the problem, we have to give neoadjuvant chemotherapy. We cannot give it in first trimester, so we can give it after first trimester. So after completion of first trimester, we can give neoadjuvant chemotherapy. We cannot give general anesthesia in first trimester, so you cannot perform surgery. But in second trimester, you can give. So MRM is done in second trimester. Radiotherapy should not be given during pregnancy. So this is given after delivery. Radiotherapy, it's given after delivery. So for locally advanced breast cancer, we go for neoadjuvant chemotherapy after first trimester, MRM in second trimester, and radiotherapy after delivery. Now we are going to discuss male breast cancer. Male breast cancer is responsible for 1% of breast cancer. And what is the most common type? Just like females, the most common type in male breast cancer is invasive ductal cancer. It's the invasive ductal cancer. Okay. Just like females, states of hyperestrogenemia is the risk factor in male breast cancer also. Whether it's endogenous estrogen or exogenous estrogen, both of these are going to increase the risk. So what's the risk factor? It's the state of hyperestrogenemia. State of hyperestrogenemia. So what are the risk factors? These are the states of hyperestrogenemia. What's the concept? You know that catabolism of estrogen occurs in the liver. So if a patient is having cirrhosis or patient is having chronic liver disease, there is relative dominance of estrogen. Levels will be raised. If there is decreased level of testosterone, in that case also there is relative dominance of estrogen. So if patient is having infertility, if there is bilateral undescended testes, if patient is having androgen insensitivity syndrome, which is also known as testicular feminization syndrome, in all these cases there is increased risk. Apart from these cases, in Klinefelter syndrome, Klinefelter's syndrome, and if patient is having BRCA2 mutation, these are going to increase the risk of male breast cancer. Basic. Another similarity, what is the most common presentation? Like females, the most common presentation is lump. What is the investigation of choice? Biopsy. And staging and treatment is similar to female breast cancer. So stage by stage treatment and prognosis is also similar. So three important points: most common presentation, lump; investigation of choice for diagnosis, biopsy; and stage by stage treatment and prognosis is similar to female breast cancer. This is Paget's disease of nipple. What you can see here, you can see that there is chronic eczematous eruption of the nipple. Another property, that in Paget's disease of nipple, there is underlying malignancy. And what's that underlying malignancy? It's ductal carcinoma in situ or invasive ductal cancer. Invasive ductal cancer. We discussed that in inflammatory breast cancer, presence of lump is not mandatory. So in this case also, presence of lump is not mandatory for diagnosis. Another important point. Second thing, how we are going to differentiate this Paget's disease of nipple from superficially spreading melanoma. So Paget's disease of nipple, it is positive for CEA, and superficially spreading melanoma, this is positive for S100. Clear? So these are the markers for these two conditions. Okay. Now how we are going to make the diagnosis? For diagnosis, we go for complete mammography. Why we go for complete mammography? To rule out occult multicentric disease. And we go for biopsy. Why? Because on biopsy you can see the Paget cells, and Paget cells are diagnostic. So for diagnosis, we go for complete mammography. plus biopsy. Complete mammography plus biopsy. And what's the treatment? The treatment is simple or total mastectomy. Is the simple or total mastectomy. See this tumor. This is Phyllodes tumor. What's this? This is Phyllodes tumor. And what are the other names of Phyllodes tumor? It is also known as cystosarcoma phyllodes, also known as serocystic disease of Brody. Okay, answers are hidden here. It is cystosarcoma phyllodes. It means in this tumor there are cystic areas. In the tumor there are cystic areas because of hemorrhage and necrosis occurring in the tumor. It is a type of sarcoma, so it will behave like sarcoma. Breast cancer is adenocarcinoma. That's why most common route of spread in breast cancer is lymphatic. This is sarcoma. So what kind of spread is there? There is hematogenous spread. So most common route of spread is hematogenous, and that's why what's the most common site of metastasis? Lungs. So the most common site of metastasis is lungs. Another important property that lymphatic spread is not seen. That's why in cystosarcoma phyllodes there is no lymph node metastasis, and if there is no lymph node metastasis, lymph node dissection is not required. Phyllodes, it means on cut section there is leaf-like appearance. What kind of appearance? Leaf-like. So its cystic tumor behaves like sarcoma, having leaf-like appearance on cut section. If you see in this tumor, typically three structures are not involved. So there is no involvement of nipple. It means there is no nipple retraction, nipple deviation and ulceration. So no nipple retraction, deviation, ulceration. Pectoralis is not involved, so generally this tumor is mobile, and breast skin is not involved, so there is no skin fixity. If you see the tumor, this affected breast is massively enlarged. Why? Because of rapid overgrowth of tumor. So affected breast is massively enlarged. If you see the appearance, it is bossylated like lipoma. So massive enlargement of breast, bossylated appearance, and third thing, because of overgrowth of the tumor, the overlying skin is stretched, and because of this stretching, you can see that there is pressure atrophy. What you can notice? Pressure atrophy. Skin is not involved, but there is pressure atrophy of the skin. We discussed it behaves like sarcoma. So most common route of spread, hematogenous. Most common site of metastasis, lungs. Here, investigation of choice for diagnosis, it's biopsy like sarcomas. And treatment, cystosarcoma phyllodes can be benign, borderline and malignant. If it is benign, what is sufficient? Wide local excision. And if it's malignant, what is sufficient? Simple mastectomy. So see, what's the treatment? If it's benign and if it's malignant, right? So in benign cases, what is sufficient? Wide local excision. And for malignant tumors, we go for simple mastectomy. Simple mastectomy. One question is asked, you want to do MRM, means MRM is done in cystosarcoma phyllodes or not? MRM is not done. Why? Because in MRM, apart from simple mastectomy, we are going to remove level 1 and level 2 lymph nodes. In cystosarcoma phyllodes, since there is no lymphatic spread, there is no lymph node involvement, that's why MRM is not done. So generally in sarcomas, there is no lymphatic spread. But there are exceptions which are frequently asked in exams. So the question is, what are the sarcomas associated with lymphatic spread? Sometimes in question, associated with lymph node metastasis, or in the question it is mentioned that sarcomas in which we perform lymph node dissection. Sarcomas in which we perform lymph node dissection. So there are 6 sarcomas in which lymphatic spread is seen. Mnemonic is MARCES. So what's the full form? M, that is malignant fibrous histiocytoma. A, angiosarcoma. R, rhabdomyosarcoma. C, clear cell sarcoma. E, epithelial sarcoma, and S, synovial sarcoma. This list is very, very important. You have to remember. So these are the sarcomas associated with lymphatic spread, associated with lymph node metastasis, and that's why in these sarcomas we go for lymph node dissection. In AIMS, there was one question: molecular classification of breast cancer is based on gene expression profiling, and this molecular classification of breast cancer is also known as luminal criteria. So see, what are the types? First is LUM A, also known as luminal A. So what is positive here? Here ER is positive, estrogen receptor, PR is positive, progesterone receptor, and HER2 new, it's negative. So you see, out of 3, 2 are positive. So this is double positive. Luminal B, in luminal B, ER is positive, PR is positive, and here HER2 new is also positive. Right? So this one is triple positive. So luminal A, this is double positive. Luminal B, this is triple positive breast cancer. If you see normal breast, like this is ER positive and well differentiated. So normal breast, like this is ER positive and it is well differentiated. Basal cell type, this is triple negative because here ER is negative, PR is negative, and HER2 new is also negative. All three are negative. That's why it's known as triple negative breast cancer, TNBC, triple negative breast cancer. So it's negative for all these, but it is positive for EGFR, myoepithelial markers, and cytokeratin. So basal cell type, you have to remember, it is positive for EGFR, myoepithelial markers, and cytokeratins. Which cytokeratins? Cytokeratin 5, 6, 17. So you have to remember cytokeratin 5, 6, 17. This is basal cell type, also known as triple negative breast cancer. And HER2 new type, common sense, here ER is negative, PR is negative. Since it is HER2 new type, so what's positive? Only HER2 new is positive. Right? Now coming to the questions. Out of these 5 types, which one is most common? So generally in majority of classifications, whatever the type is based on the top, located on the top, that's most common. So here, it's most common type, luminal A. And this is having best prognosis. Why? Because if you see the prognostic factors, ER/PR is positive, it's a good prognostic factor. HER2 new is negative, that's also a good prognostic factor. Out of these 5, which one is having worst prognosis? So it's HER2 new type. This one is having worst prognosis. It's very easy to understand the multi-gene test. Imagine there is a female patient. ये पूरा edit कर देना. It's very easy to understand the multi-gene test. Imagine there is a newly diagnosed case of breast cancer. In that patient, on the biopsy specimen, we are going to see the expression of multiple genes. On the basis of expression of multiple genes, we are going to predict responsiveness of chemotherapy, likelihood of survival, and likelihood of recurrence rate. So these tests are based on expression of multiple genes, and that's why what's the name? Multi-gene tests. So these multi-gene tests are going to predict responsiveness to chemotherapy, likelihood of survival, and likelihood of recurrence rate. So what are the commonly used multi-gene tests? One was asked in AIMS, Oncotype DX. How many genes are assessed in Oncotype DX? 21. Second is PAM50. So name is PAM50. So how many genes are assessed? 50. And in MammaPrint, how many genes are assessed? 70. Now see, the question related to Oncotype DX. Apart from breast, it is also used for colon and prostate. So apart from breast, it's used for colon and prostate. This is Oncotype DX, a type of multi-gene test. Nowadays, generally BRCA1 and BRCA2 is asked almost every year. First, see the similarities. BRCA1 and BRCA2, both of these are going to increase the risk of breast cancer. Which type of breast cancer? Invasive ductal cancer. There is early age of onset and it's bilateral. So, three similarities: invasive ductal cancer, early age of onset, and it's bilateral. See the differences. BRCA1, it is located on chromosome number 17 and BRCA2 is located on chromosome number 13. In the beginning, we discussed that BRCA1 is mainly responsible for breast cancer in females. BRCA2, it's mainly responsible for breast cancer in males, mainly. Differences: BRCA1, these tumors are hormone receptor negative and poorly differentiated, whereas BRCA2, these tumors are hormone receptor positive and well differentiated. So here this is hormone receptor negative and this is poorly differentiated. This one is hormone receptor positive and this is well differentiated. Okay, now see, apart from breast, there is increased risk of other malignancies like ovary, colon and prostate. So here there is increased risk of OCP, ovary, colon, prostate. Apart from breast, increased risk of ovary, colon and prostate malignancies. If you see BRCA2, apart from ovary, colon, prostate, there is increased risk of pancreas, gallbladder, stomach and melanoma. So how to remember? The mnemonic is OCP and GSM. OCP and GSM. Clear? So O means obviously ovary, C means colon, P means prostate, G means gallbladder, S means stomach, M means melanoma. Stomach, melanoma. Clear? Apart from this, there is another malignancy. Here you have to add pancreas. P means pancreas. So these are the malignancies whose risk is increased. These are the differences. There was one question in JIPMER that if a patient is having BRCA1 mutation, how much is the lifetime risk of development of breast cancer and development of ovarian cancer? So in BRCA1 mutation, the lifetime risk of development of breast cancer, that's 60 to 80%. And how much is the lifetime risk of development of carcinoma ovary? It's 30 to 40%. How to remember? The risk of development of carcinoma ovary is just half of the risk of breast cancer. It's very, very important. You have to remember. Now see, the risk of breast cancer associated with benign breast conditions and carcinoma in situ. So if we see non-proliferative lesions, sclerosing adenosis, duct papilloma, how much is the relative risk? There is no risk. There is no increased risk. If we see florid hyperplasia, how much is the risk? In this case, 1.5 to 2 folds. How much is the risk? 1.5 to 2 folds. In atypical ductal hyperplasia and atypical lobular hyperplasia, how much is the relative risk? It's 4 folds. This is the question which is frequently asked, that if there is ductal involvement by the cells of atypical ductal hyperplasia, then the risk becomes 7 folds. And you know, in ductal carcinoma in situ and lobular carcinoma in situ, how much is the risk? 10-fold. So maximum risk in DCIS, LCIS, atypical ductal hyperplasia, atypical lobular hyperplasia, 4-fold. And whenever there is ductal involvement by the cells of atypical ductal hyperplasia, then it's 7-fold. So you have to remember this chart is very, very important. What is the full form of ANDI? Aberrations in normal development and involution. Is the aberrations in normal development and involution. Now see what is the most common type of ANDI if the patient's age is 15 to 25 years. You must be knowing in young females it's fibroadenoma. It is fibroadenoma. In 25 to 40, it is fibroadenosis, and these patients are coming to us with serous discharge. So in this particular age group, it's fibroadenosis. And if the age of female is more than 40, here also the most common type is what? Fibroadenosis, followed by ductictasia. So 15 to 25 years fibroadenoma, 25 to 40 fibroadenosis, more than 40 fibroadenosis followed by ductictasia. Fibroadenoma is also asked frequently. It is also known as breast mouse. So why it's known as breast mouse? Because the tumor is highly mobile. It is seen in young females. The lump is firm, it's mobile. What is the investigation of choice for diagnosis? The investigation of choice for diagnosis, it is FNAC. And we discussed if you go for mammography, what kind of calcification is seen? Generally we don't go, but if we go for mammography, what kind of calcification we discussed? It's popcorn calcification. And in fibroadenoma, generally what's the treatment? Observation, right? But if patient insists for excision or for cosmetic region, so if patient insists, then we go for excision. So treatment is excision if there is fear or for cosmetic regions. Okay, so this is how we manage fibroadenoma. This image-based question is trending nowadays. It was asked in NEET PG also, it was asked in FMG also, it was asked in AIIMS also. So what is the name of this condition? Here you can see that there is a vein, superficial vein, which is thrombosed. So there is thrombophlebitis of superficial inframammary vein, and this is known as Maunders disease. What's the other name? It looks like cord or string. So other name is string phlebitis. So what is this Maunders disease? It's the superficial thrombophlebitis of inframammary vein. Which vein? Lateral thoracic and thoracoepigastric. So which vein? Here, superficial thrombophlebitis of inframammary vein. There is involvement of lateral thoracic and thoracoepigastric vein. Clear? It looks like string or cord, that's why it's known as string phlebitis. In this image you can see that affected breast is engorged, the skin is erythematous, and here you can see that when incision was given, you can see pus coming out. So what is the diagnosis? This is breast abscess. You know, breast abscess is more common in lactating females, especially preemies, because of faulty breastfeeding technique. What's the most common organism responsible for breast abscess? Yes, it is Staph aureus. So this is a case of breast abscess. Breast abscess. Important questions that it is generally seen in lactating females. Okay, which types? Preemies, because of faulty breastfeeding technique, there is trauma around the nipple. Which organism is responsible? The most common organism responsible is Staph aureus. Since there is abscess, so we discussed that if there is pus collection somewhere, what are the signs and symptoms? If there is pus collection, there is pain, there is tenderness, there is erythema. Here you can see the breast is engorged, and if you take the temperature over the surface of breast, it is raised. Since there is pus collection, patient will be having fever with chills and rigor. So I'm repeating, breast is engorged, there is pain and tenderness, skin is erythematous, there is fever with chills and rigor, temperature over the surface of breast is raised. How to differentiate breast abscess from inflammatory breast cancer? In inflammatory breast cancer, 33%, at least 33% of breast skin is involved by inflammatory changes, but there is no fever and the temperature over the surface of breast is not raised. Clear? So this is breast abscess. How we are going to treat? Obviously, it's the incision and drainage plus antibiotics. And this was the question in NEET. Which antibiotic? What is the first line agent? We give cloxacillin cloxacillin or dicloxacillin. We give cloxacillin or dicloxacillin for how many days? 10 to 14 days. How many days? 10 to 14 days. So generally they are asking image based questions in relation to breast abscess nowadays. There is a condition which is common in smokers, that is recurrent periductal mastitis. And what's the name of this condition? It's known as Zuska's disease. What's the name? It's Zuska's disease. This was also asked in DNB. So this is more common in females who are smokers. Catch point is common in smokers. What is the other name of this Zuska's disease? Recurrent periductal mastitis. So these patients are coming to you with recurrent periductal mastitis or recurrent breast abscess. So the other name is recurrent periductal mastitis. If this female is also coming to you with breast abscess, obviously what's the treatment? Incision and drainage with antibiotics. So this is all about breast. Now we are going to discuss thyroid. First of all, we are going to discuss congenital condition, that is thyroglossal cyst. This is thyroglossal cyst. We discussed that it is congenital. Despite of being congenital, what is the age of presentation? The age of presentation is 15 to 30 years. So first important point, that it is congenital. Despite of being congenital, what is the age of presentation? It is 15 to 30 years. Okay. And what's the most common location? If you see the cyst, the most common location is subhyoid. So what's the most common location or most common site? This is important. It is subhyoid. Okay. What is the presentation? So here you can see it's a midline swelling. So patient presents with midline swelling in the anterior part of neck. It moves with deglutition just like other thyroid swelling. One special property is there in thyroglossal cyst, that it moves up on protrusion of tongue. So midline swelling in anterior part of neck, moves up during deglutition. So midline swelling in anterior part of neck, moving well with deglutition, and it moves up on protrusion of tongue. What are the complications of thyroglossal cyst? So sometimes there is infection of thyroglossal cyst. And if there is infection, what's the problem? Because of this infection, there is abscess, right? And if there is abscess formation, and what's the problem? If IND is done, in the abscess, if incision and drainage is done, what will happen? This thyroglossal cyst will convert into thyroglossal fistula. So the problem, it will convert into thyroglossal fistula. So question, thyroglossal cyst, it's congenital. But if we see thyroglossal fistula, it is acquired. It's acquired. This is one complication. Second, you know that thyroglossal cyst increases the risk of malignancy. It increases the risk of which malignancy? Papillary carcinoma thyroid. Clear? What's the treatment of choice? The treatment of choice is cyst trunk operation. It's the cyst trunk operation. And what we are going to remove in cyst trunk operation? In this case, we are going to remove the cyst along with central part of body of hyoid. So this is en bloc removal of cyst along with central part of body of hyoid. So this is cyst trunk operation done for thyroglossal cyst. Certain definitions are asked in exam. First, what is the definition of endemic goiter? When more than 5% people in the population are having goiter, it is endemic. More than 5% people in the population are having goiter. This is endemic goiter. There is another definition, retrosternal goiter. What are the other names for retrosternal goiter? It is also known as substernal goiter, also known as mediastinal goiter. What is the definition? When more than 50% of thyroid tissue is located below the opening of thoracic cage. This is substernal or mediastinal goiter. What's the good thing? That in majority of patients it is asymptomatic, right? That's why incidentally diagnosed on radiological investigations. But what is the problem? Whenever you can see the 50%, more than 50% of thyroid will go below the opening of thoracic cage, it starts compressing the midline structures. So what are the clinical features? In symptomatic patients, we discussed majority of patients are asymptomatic, but in symptomatic patients, the most common symptom is dyspnea. And this is marked at night. Why there is dyspnea? Whenever there is compression of trachea. If there is compression of esophagus, there is dysphagia. And whenever there is compression of recurrent laryngeal nerve, these patients have hoarseness of voice. If you examine, you are going to find that there is presence of dilated veins over anterior chest wall. And whenever we ask the patient to elevate both upper limb above forehead, you will notice facial puffiness or congestion, and that's known as Pemberton sign. So in these patients, Pemberton sign is positive. One question is asked, obviously we go for thyroidectomy. So which incision is preferred for thyroidectomy? It's the cervical incision. So in treatment, which incision is preferred? So in treatment, we perform thyroidectomy, and this thyroidectomy is done by cervical incision. So it's done by cervical incision. What are the commonly used radioisotopes in thyroid disorders? One is iodine 123 and the second is iodine 131. Second question, what's the half-life of iodine 123? It is 13 hours. And what's the half-life of iodine 131? It is 8 days. So iodine 123 is having shorter half-life. That's why it is used for diagnostic purpose, and it is used for radioactive iodine scan. Iodine 131 is having longer half-life, and that's why it is used for both diagnostic, mainly used for therapeutic purpose. It means it can be used for radioactive iodine scan also. But what's the main use? Radioactive iodine ablation is the radioactive iodine ablation. Another question, this iodine 131, it is going to emit what? Beta rays, and it is going to emit what? Gamma rays. How much beta? 90% of beta and 10% gamma. Out of beta and gamma, which one is responsible for therapeutic effect? It's the beta rays. Depth of penetration of beta rays is 0.5 mm. So it is just going to destroy thyroid. Even parathyroid is spared. Important question. So beta rays, this is responsible for therapeutic effect. Responsible for therapeutic effect. And how much is the depth of penetration? You have to remember 0.5 mm is the depth of penetration. What's the problem with gamma rays? Gamma rays is used in tracer studies, but the problem, gamma rays are responsible for side effects. So gamma rays, it is used in tracer studies, but it's responsible for side effects. Simple. So you tell me, what are the absolute contraindications of radioactive iodine ablation? Because we are giving iodine 131, so there is emission of gamma rays. What? Pregnancy and lactation. Because of this emission of gamma rays, the absolute contraindications. The absolute contraindications of radioactive iodine ablation are pregnancy and lactation. Pregnancy and lactation. See the image-based questions related to radioactive iodine scan, which is also known as thyroid scan. So first see how this normal thyroid scan looks like. Here you can see uptake by the both lobes of thyroid. What is problem in hot nodule? If you notice, relatively there is increased uptake. So in hot nodule, there is a nodule with relatively increased uptake as compared to surrounding tissue. And in cold nodule, you are going to notice that there is a nodule with relatively decreased uptake as compared to surrounding tissue. So here you can see this is hot nodule, and here relatively decreased uptake, this is the cold nodule. Out of hot nodule and cold nodule, which one is having higher risk of malignancy? So in hot nodule, the risk of malignancy is 1 to 3%. You have to remember the percentage. And in the cold nodule, how much? 17 to 20%. It is 17 to 20%. See this Graves' disease. Graves' disease is also known as diffuse toxic goiter. So in the whole thyroid, relatively there is increased uptake. So there is increased radioactive iodine uptake. So here you can see that there is diffuse toxic goiter. You can notice that in both lobes there is increased uptake. This is multinodular goiter. What kind of toxic multinodular goiter? So in toxic multinodular goiter, you will find certain nodules which are having increased uptake and certain nodules which are having decreased uptake. Means both hot as well as cold nodules will be there. So if you see, this is the appearance. Both hot as well as cold nodules will be there. So this is toxic multinodular goiter. In thyroiditis, there is inflammation of thyroid tissue, and in most of thyroiditis, relatively there is decreased radioactive iodine uptake. It is generally seen that radioactive iodine uptake is less than 5%. So here you can see hardly there is any uptake on the radioactive iodine scan. So these are the various image based questions related to radioactive iodine scan, which is also known as thyroid scan. Now we are going to discuss various types of thyroidectomy. In this image you can see almost whole thyroid tissue is removed. So removal of all visible thyroid tissue, and this is known as total thyroidectomy. Total thyroidectomy, removal of all visible thyroid tissue. In this image you can see that one lobe with isthmus is removed. So if there is removal of one lobe with isthmus, this is known as what? Hemithyroidectomy. In subtotal thyroidectomy, what we do, we leave 3 to 4 grams of thyroid in each lobe superiorly. How much? 3 to 4 grams of thyroid in each lobe superiorly with removal of rest of the thyroid gland, and that is what? Subtotal thyroidectomy. Rather than going for subtotal thyroidectomy in which 3 to 4 grams are removed in both lobes, we are going to remove 4 to 6 grams of thyroid in one lobe only, and that is known as Hartley-Dunhill procedure. So here you can see we are going to leave 4 to 6 grams of thyroid in one lobe only with removal of rest of the thyroid gland. This is known as Hartley-Dunhill procedure or Hartley-Dunhill operation. In near total thyroidectomy, we are leaving just less than 1 gram. How much? Less than 1 gram of thyroid tissue adjacent to which nerve? Recurrent laryngeal nerve near ligament of Berry. So leaving less than 1 gram of thyroid tissue adjacent to recurrent laryngeal nerve near ligament of Berry, and this is known as near total thyroidectomy. So these are the various types of thyroidectomy. What are the indications of these surgeries? Imagine a patient who is having benign disorder involving one lobe only. Which of the following surgery should be preferred? So obviously for benign disorder involving one lobe only, we go for hemithyroidectomy. So it is done for benign disorders involving one lobe. Benign disorders involving one lobe. Okay. Second question. If a patient is having thyroid malignancy, which of the following surgery should be preferred? So obviously for thyroid malignancy, total thyroidectomy is preferred. Second question, if a patient is having benign disorder involving both lobes or benign disorder in which both lobes are involved, in that case also we go for total thyroidectomy. So this total thyroidectomy, it is done for thyroid malignancy. So first, it's done for thyroid malignancy, and it's also done for benign disorders involving both lobes. Benign disorders involving both lobes. Okay. What's the indication of subtotal thyroidectomy? Usually it's not done nowadays. It is done only in elderly patients who are having multinodular goiter. So indication of subtotal thyroidectomy, it's the multinodular goiter in elderly. in elderly. So these are the indications of these surgeries. Solitary thyroid nodule is frequently asked question. What is the most common solitary thyroid nodule? It is colloid goiter followed by follicular adenoma. So first important question, the most common solitary thyroid nodule, it is colloid goiter followed by follicular adenoma. Okay. Second question, what's the first investigation done in solitary thyroid nodule? It is thyroid function test. And what is the investigation of choice for diagnosis of solitary thyroid nodule? That is FNAC. So first investigation done in solitary thyroid nodule, it is thyroid function test, right? And if the question is asked, what is the investigation of choice for diagnosis of solitary thyroid nodule, and then it is FNAC. Let me tell you, for most of thyroid disorders, investigation of choice for diagnosis is FNAC for majority of conditions. But there are certain limitations of FNAC. So what are the limitations of FNAC? So what are the limitations of FNAC? First is follicular neoplasm. It means it cannot differentiate follicular adenoma from follicular carcinoma. Why? Because the diagnosis of malignancy is based on vascular invasion or capsular invasion, which is detected on biopsy. So FNAC cannot detect vascular invasion or capsular invasion. That's why what the first limitation is, it cannot differentiate follicular adenoma from follicular carcinoma. So it's the follicular neoplasm. What's the problem in Riedl's thyroiditis? In Riedl's thyroiditis, the whole thyroid is replaced by fibrous tissue. So the yield is very low. So second limitation, Riedl's thyroiditis. And you know, in the body, lymphoma anywhere in the body, investigation of choice for diagnosis is biopsy. So for any lymphoma anywhere in the body, investigation of choice for diagnosis is biopsy. So thyroid lymphoma is also a limitation. So these are three limitations of FNAC. For most of the thyroid disorders, investigation of choice for diagnosis is FNAC. How we are going to manage the solitary thyroid nodule? So we discussed investigation of choice for diagnosis of solitary thyroid nodule. It is FNAC. Whenever we perform FNAC, there are four findings only. Either it can be inconclusive, it's benign, it's suspicious, or it's malignant. If it is inconclusive, what we do? We repeat the FNAC. So you do repetition, repeat FNAC. In benign disorders, the lesion can be cystic, or it can be solid. If there is cystic lesion, we go for aspiration. Despite of aspiration, if there is recurrence, we go for re-aspiration. So what? Go for aspiration. And if there is recurrence, we go for re-aspiration. Maximum for how many times re-aspiration is done? 3 times. Even after 3 times of re-aspiration, there is recurrence. In that case, we go for hemithyroidectomy. Benign disorder involving one lobe, hemithyroidectomy. If it's a solid lesion, in that case, we consider thyroxine therapy. So we give thyroxine therapy. Despite of thyroxine therapy, if there is no improvement or there is compression symptoms, in those cases we go for hemithyroidectomy. No improvement or compression symptoms. In suspicious lesions, we perform radioactive iodine scan. On radioactive iodine scan, two findings are there. Either it's hot or it's cold. So imagine there is hot nodule. A second situation, there is cold nodule. So you know, in cold nodule, there is relatively decreased radioactive iodine uptake. So for cold nodule, we have one option, and that's hemithyroidectomy. In hot nodule, either you can go for hemithyroidectomy or we can go for radioactive iodine ablation. Radioactive iodine ablation. And if there is malignant nodule or malignancy, obviously what is the preferred treatment? It's the total thyroidectomy. So this is how we manage solitary thyroid nodule. Most common cause of hypothyroidism worldwide is Hashimoto's thyroiditis. And what is the most common cause of hyperthyroidism worldwide? That is Graves' disease. So we are going to discuss Graves' disease first. Graves' disease is also known as diffuse toxic goiter. What's the other name? It's also known as diffuse toxic goiter. Okay. What is the association of Graves' disease? It is associated with HLA-B8 and DR3. So another important point, it is associated with HLA-B8 and DR3. Graves' disease and Hashimoto's thyroiditis are autoimmune disorders. And you know, autoimmune disorders are more common in females. All thyroid related disorders are more common in females. That's why in this chapter we are not going to say which one is more common in male or female. All thyroid related disorders more common in females. So in Graves' disease, since it's an autoimmune disorder, what's the name of autoantibody? In short, it's known as LATS. That is long acting thyroid stimulator. So there is thyroid stimulating autoantibodies against which receptor? Against TSH receptor. Clear? So long acting thyroid stimulator against TSH receptor. How it works is very easy to understand. Imagine this is TSH hormone. This TSH hormone works on TSH receptor, and if it works on TSH receptor, there is secretion of T3 and T4. And you know, this T3 is going to inhibit, there is feedback inhibition of secretion of TSH. What is the problem? Whenever there is long-acting thyroid stimulator or autoantibody which is stimulatory, it is going to stimulate TSH receptor, so there is increased production of T3, T4. And because of feedback inhibition of TSH, there is decreased TSH. So what is the profile here? If you see, in this case, there is increased T3, there is increased T4, and there is decreased TSH. So this patient will be having signs and symptoms of hyperthyroidism. There is excessive production of T3, T4. So this patient is having thyrotoxicosis. So what are the characteristic features of Graves' disease? So there is thyrotoxicosis we discussed. There is ophthalmopathy. And what is the other name of this ophthalmopathy? This is also known as exophthalmos. Right? So here what is the problem? There is collection of loose areolar tissue behind the eyeball, and that's why there is exophthalmos. That's also known as ophthalmopathy. This was image based question in AIIMS. Here you can see there is pretibial myxedema because of deposition of glycosaminoglycans. It is non-pitting edema. What's the name? Pretibial myxedema because of deposition of glycosaminoglycans. And what's the name? It is dermopathy. Pretibial myxedema can be seen in Hashimoto's thyroiditis also. There can be acropathy. Acropathy means there is subperiosteal new bone formation in metacarpals, and there can be gynecomastia. So these are the characteristic features. If you see the clinical features, there are two kinds of symptoms which are going to predominate. One is because of sympathetic stimulation and one is because of thyroid stimulation. So why there is sympathetic stimulation symptoms? You know that in patients of hyperthyroidism, there is increased expression of beta receptors. Because of increased expression of beta receptors, there are sympathetic stimulation symptoms. Okay, and that's why in the treatment, what is the first drug given in the patients of hyperthyroidism? Yes, it is propranolol. Why? To control the sympathetic stimulation symptoms. So what are the symptoms? Patient is having tachycardia, there is palpitation, excessive sweating, and there is fine tremors, presence of fine tremors. Where we are going to see these fine tremors? In the fingers and in the tongue. So fine tremors, these are seen in fingers and tongue. In fingers and tongue. Now see the thyroid stimulation symptoms. You know, thyroid hormones are going to increase the basal metabolic rate. Because of this increased basal metabolic rate, there is increased appetite, and despite of increased appetite, there is weight loss. You know that in patients of hypothyroidism, there is decreased basal metabolic rate, and in those patients, there is decreased appetite. Despite of that, there is weight gain. So here, increased appetite, despite of that, there is weight loss, there is excessive sweating. These patients have heat intolerance, and what is the problem? There is diarrhea. Diarrhea is the most common GI symptom of Graves' disease. Diarrhea is the most common GI symptom of Graves' disease. Now, what is the problem in females? In females, there is amenorrhea, increased risk of abortions and infertility. Females, there is amenorrhea, increased risk of abortions and infertility. Okay. And what's the problem in children? In children, there is early growth and maturation. So the problem in children, there is early growth and maturation. Okay. Right. Another important point. In patients of Graves' disease, which symptoms are predominant in young patients? So in young patients, which symptoms are predominant? Yes, it's the CNS symptoms. It is CNS symptoms, and in elderly, it is CVS symptoms, particularly AF and CHF. What? Atrial fibrillation and congestive heart failure. So young patients, CNS symptoms are predominant. In elderly, CVS symptoms are predominant. Now, what are the findings of thyroid gland? Special features of this thyroid gland in patients of Graves' disease. So in patients of Graves' disease, thyroid gland is hyperactive, and because of this hyperactivity, what is increased? There is increased radioactive iodine uptake. Second, this gland is hypervascular. So thyroid gland is hypervascular, and the signs of hypervascularity, this is most prominent at upper pole. Right? So whenever we are going to palpate upper pole, you can palpate a thrill. So there is palpable thrill, there is audible bruit, and there is audible venous hum. These are most prominent at which pole? Upper pole. Palpable thrill, audible bruit, and audible venous hum. This is because of hypervascularity. Now coming to the diagnosis, it's very easy to make the diagnosis. See, if there is presence of eye signs in the patient of hyperthyroidism, diagnosis of Graves' disease is confirmed. So presence of eye signs in patients of hyperthyroidism. If there is presence of eye signs in patients of hyperthyroidism. Imagine eye signs are not there. What is a single investigation which can confirm the diagnosis? So in autoimmune disorder, one of the characteristic feature is presence of autoantibodies. If you are going to detect autoantibodies, presence of autoantibodies are going to confirm the diagnosis. This is a single investigation which can confirm the diagnosis, and we discussed in Graves' disease there is increased radioactive iodine uptake. Now coming to the management, we discussed that for sympathetic stimulation, what is the drug which should be given? So first drug given in Graves' disease patient is propranolol. So how we are going to management? The first drug which is given, and that's propranolol. Okay, to control the sympathetic stimulation symptoms. To control the overproduction of T3 and T4, we have to give anti-thyroid drugs. So what are the anti-thyroid drugs used? We use methimazole, carbimazole, propyl thiouracil. First, understand what are the side effects of methimazole. So methimazole increases the risk of choanal atresia. First problem, choanal atresia, frequently asked. Second is aplasia cutis. And third, generally with most of antithyroid medications, there is agranulocytosis. Okay, it means this is not safe during pregnancy. Why? Because there is increased risk of congenital malformations. Okay. Second, what's the problem with propyl thiouracil? That it is going to increase the risk of hepatic failure in females and children. So there is increased risk of hepatic failure in females and children. It means again it's not very safe in pregnancy. Why? Because in females there is increased risk of hepatic failure. But there is a good feature of propylthiouracil that it blocks peripheral conversion of T4 to T3. So this feature makes it antithyroid drug of choice in thyroid storm. Now coming to the question, what is the antithyroid drug of choice in Graves' disease? So this is methimazole. If nothing is mentioned, it's methimazole. And if it is asked antithyroid drug of choice in pregnancy, so in pregnancy it is carbimazole. It is carbimazole. And what is the drug of choice, antithyroid drug of choice in thyrotoxic crisis? This is propylthiouracil. It's the propylthiouracil. Okay, so these are the drugs which are given to make the patient euthyroid, so that before surgery patient should be euthyroid. If you're talking about the treatment of choice, we discussed that if some disorder is involving thyroid gland diffusely, what is the preferred surgical treatment? Total thyroidectomy. So what's the treatment of choice for Graves' disease? It's the total thyroidectomy. Okay, certain patients who cannot tolerate surgery or because of certain contraindications of surgery, what's the alternative treatment? We can go for radioactive iodine ablation. So the treatment of choice is total thyroidectomy. Alternative treatment is radioactive iodine ablation. Most common cause of hypothyroidism worldwide is Hashimoto's thyroiditis. It is also an autoimmune disorder. What is the other name? It is known as struma lymphomatosa. What is the meaning? In Hashimoto's, there is conversion of thyroid tissue into lymphoid tissue. So struma lymphomatosa means conversion of thyroid tissue into lymphoid tissue. One question is asked that Hashimoto's thyroiditis increases the risk of which malignancy? So it's hidden in the term lymphomatosa. What? Lymphoma. Apart from lymphoma, it also increases the risk of papillary carcinoma thyroid. So first important point here, it increases the risk of thyroid lymphoma and papillary carcinoma thyroid. Okay, it's an autoimmune disorder. So which antibodies? There is presence of anti-thyroid peroxidase. Anti-thyroid peroxidase. Here it is associated with HLA, B8, DR3 and DR5. HLA, B8, DR3, DR5. What is the problem here? There is CD4 mediated CD8 cytotoxicity. Because of that, there is permanent destruction of follicles. And if there is permanent destruction of follicles, these patients are going to develop permanent hypothyroidism. What kind of? Permanent hypothyroidism. And if patient is going to develop permanent hypothyroidism, for how long we have to give levothyroxine? Lifelong. So we have to give levothyroxine lifelong in patients of Hashimoto's thyroiditis. Now coming to the clinical features. So obviously these patients will be having what? Signs and symptoms of hypothyroidism with enlargement of thyroid gland. So generally it's not well defined. So if you're going to take neck circumference, it is increased. So in this patient you can notice that patient is having Hashimoto's thyroiditis with increased circumference of neck. Another easy question, what is the investigation of choice for diagnosis? In autoimmune disorder, detection of autoantibodies. So here you can see presence of anti-TPO is diagnostic. If you want to perform FNAC, what's the finding? So one thing you're going to find in FNAC, the name is Hashimoto's thyroiditis or struma lymphomatosa. So there is lymphocytic infiltration. Apart from increased lymphocytic infiltration, the characteristic cells are seen. Name, Hurdle cells. This question is asked in exam. Hurdle cells, also known as Eskenazi cells. So Hurdle cells or Eskenazi cells, these are seen on FNAC. What is the treatment? Patient is having permanent hypothyroidism. So we give, since permanent hypothyroidism is there, we give lifelong levothyroxine. Lifelong levothyroxine. Another feature, Second, we discussed that in this patient there is increased risk of lymphoma and papillary carcinoma thyroid. So if we are suspecting malignancy in patients of Hashimoto's thyroiditis, what is the preferred treatment? Thyroidectomy. So whenever we suspect malignancy, and in cases of malignancy, what we go for? We go for total thyroidectomy. So this is how we manage Hashimoto's. Now we are going to discuss subacute thyroiditis. These are the names of subacute thyroiditis. It is also known as de Quervain's thyroiditis, also known as viral thyroiditis, granulomatous thyroiditis, or giant cell thyroiditis. The features of subacute thyroiditis are hidden in these terms. See, in this patient, generally there is upper respiratory tract infection by virus. That's why it's known as viral thyroiditis. Because of this viral infection, there is granulomatous inflammation. That's why known as granulomatous thyroiditis. Because of this granulomatous inflammation, you will find that there is follicle destruction and presence of giant cell. So there is giant cell formation and there is follicle destruction. So whenever we perform FNAC is investigation of choice, you are going to find presence of multinucleated giant cells. Clear? So investigation of choice for diagnosis, FNAC, and what we are going to find, yes, multinucleated giant cell. Because of granulomatous inflammation, there is follicle destruction. If there is follicle destruction, there is release of T3, T4. So patient is having hyperthyroidism. After some days, T3, T4 which is released is used up. Patient becomes euthyroid. After some days, since there is no further, because follicle is destroyed, so no further release of T3, T4. So patient becomes hypothyroid, and ultimately in 90% patients there is spontaneous resolution. So patient become euthyroid. So initially hyperthyroid, then euthyroid, then hypothyroid, and ultimately in 90% patients because of spontaneous resolution, patient becomes euthyroid. So what are the clinical features? Easy to remember. In this patient, there is inflammation or thyroiditis. So because of inflammation, what is the problem? There is pain, there is tenderness. Common sense question, pain and tenderness. Okay. Second, this patient can have signs and symptoms of hypothyroidism or hyperthyroidism, and it is dependent on the stage of disease. So apart from pain or tenderness, patient can have signs and symptoms of either hypo or hyperthyroidism. Okay. It is dependent on the stage of disease. Since follicle is destroyed, if we are going for radioactive iodine uptake, what happens? Because of destruction of follicle, there is decreased radioactive iodine uptake. It is inflammatory disorder, so ESR is raised or decreased. So it is associated with increased ESR. Okay, so it is associated with decreased radioactive iodine uptake and increased ESR. Simple. How we are going to manage? It's an inflammatory disorder. Inflammation is there. So for management, what? Control the inflammation. So how we control inflammation? First, we give NSAIDs. And if it's not controlled by NSAIDs, patients are not improving, then we add or give steroids. What's the good thing? In 90% patients, there is spontaneous resolution. There is spontaneous resolution in subacute or de Quervain's thyroiditis. Now we are going to discuss Riedel's thyroiditis. What is the other name? Riedel's thyroiditis is also known as invasive fibrous thyroiditis. What's the problem here? Invasive fibrous thyroiditis. So in this case, you can see both thyroid as well as parathyroid gland. Both thyroid as well as parathyroid gland, these are completely replaced by fibrous tissue. So if thyroid and parathyroid is completely replaced by fibrous tissue, name is invasive fibrous thyroiditis. It means these patients will be having signs and symptoms of hypothyroidism and hypoparathyroidism. parathyroidism. Hypothyroidism and hypoparathyroidism. It means in the management, it's clear that we have to give lifelong levothyroxine and we have to give lifelong calcium and vitamin D supplementation. So we have to give lifelong vitamin D and calcium supplementation for hypoparathyroidism, and for hypothyroidism lifelong levothyroxine. This is one problem. Second problem, because of this invasive fibrous thyroiditis, there are compression symptoms. So it is going to compress trachea, esophagus, recurrent laryngeal nerve. So there is dyspnea, dysphagia and hoarseness of voice. When we perform the examination, this thyroid becomes hard and woody. So here you can see how thyroid becomes, it's hard and woody, right? And because of this, what is the problem? There is compression of midline structures like trachea, esophagus and recurrent laryngeal nerve. Coming to the diagnosis, we discussed that here there is complete replacement of thyroid and parathyroid by fibrous tissue. So if you are going for FNAC, there is no yield. There is no yield. So what we go for? We go for wedge-shaped excision biopsy. We go for wedge-shaped excision biopsy, and in this what we remove the isthmus. So it is going to control the compression symptoms. So investigation of choice. Here, investigation of choice for diagnosis, it's the wedge-shaped excision biopsy. Wedge-shaped excision biopsy. Simple. Now coming to the management. So in the management, we go for wedge-shaped excision, one part of management to control the symptoms of compression. Patient is having hypothyroidism. That's why we give lifelong levothyroxine. We give lifelong levothyroxine. And since patient is having hypoparathyroidism, that's permanent, we give calcium and vitamin D supplementation. Calcium and vitamin D supplementation. So this is how we manage Riedel's thyroiditis. Now we are going to discuss thyroid malignancy. First question, what's the most common thyroid malignancy? It's the papillary carcinoma, followed by follicular, followed by medullary, followed by anaplastic. Most common type is papillary, followed by follicular, followed by medullary, followed by anaplastic. If you see the features here, this papillary carcinoma, it is seen in relatively young patients, age approximately 25 to 40. It is seen in iodine sufficient areas. Follicular carcinoma, generally it is seen in 6th decade, 5th to 6th decade, seen in iodine deficient areas. So these patients are already having goiter, and in long-standing goiter, there is development of follicular carcinoma. So question is asked, most common thyroid malignancy seen in patients having long-standing goiter, and that is follicular. Medullary carcinoma, again it is seen in 5th to 6th decade. It is associated with MEN2A2B. There is association with MEN2A2B. And anaplastic, if you see, the age is 7th to 8th decade. It's rare. Okay, so on the basis of age also you can make the diagnosis. One by one we are going to discuss. First we are going to discuss papillary carcinoma. So we discussed this is the most common thyroid malignancy. It is seen in iodine sufficient areas where the iodine intake is sufficient. What is the risk factor? Low dose radiation exposure, especially during childhood, increases the risk. You have to remember the term low dose radiation exposure. Okay, during childhood, especially during childhood. We discussed two conditions which are going to increase the risk of papillary carcinoma. In the beginning, we discussed thyroglossal cyst. So thyroglossal cyst increases the risk, and second is Hashimoto's thyroiditis. Hashimoto's thyroiditis and thyroglossal cyst increases the risk of papillary carcinoma. This is one of the most commonly asked image-based question. It is asked almost every year. So here you can see there is optically clear nuclei, and this is also known as orphan any eye nuclei. Can you see this orphan any? Yes, orphan any eye nuclei. So this is orphan any eye nuclei. Optically clear nuclei, also known as orphan any eye nuclei. What are the other features? It's papillary carcinoma. So there are papillary projections. There is presence of pseudo inclusion bodies and dystrophic calcification. What's the name of this dystrophic calcification? Psammoma bodies. Apart from papillary carcinoma thyroid, psammoma bodies are also seen in other tumors. So in which tumors psammoma bodies are seen, the mnemonic is PSM. It is the PSM. So first, papillary carcinoma thyroid. Second, papillary variant of RCC. Third, serous cystadenoma ovary. And fourth, meningioma. Right? So in these, there is dystrophic calcification, which is also known as psammoma bodies. Now coming to the clinical features. Since patient is having thyroid malignancy, so what is the presentation? There is midline swelling in the anterior part of neck. There is another feature of papillary carcinoma thyroid that's known as lateral aberrant thyroid. So you are going to palpate a lateral cervical lymph node having metastatic deposit from papillary carcinoma thyroid. Lateral palpable cervical lymph node, yes, with metastatic deposit from papillary carcinoma thyroid, and that's known as lateral aberrant thyroid. So two presentations. One, either patient is having midline mass and sometimes patient is having lateral aberrant thyroid. So it's clear what's the most common route of spread? Lymphatic. And what is the most common site of metastasis? It is lungs. Another important point, most common route of spread, that is lymphatic. And what is the most common site of metastasis? It is lungs. In thyroid disorders, investigation of choice we already discussed. Investigation of choice for diagnosis, that's FNAC. Clear? Now how we are going to treat it? It's a thyroid malignancy. So obviously we have to perform total thyroidectomy. In thyroid malignancy we perform total thyroidectomy. Most common route of spread, lymphatic. So whenever we are performing thyroidectomy, if there are enlarged central group of lymph nodes, we have to remove that. So removal of enlarged central group of lymph nodes. Okay, plus minus ipsilateral MRND. MRND means modified radical neck dissection, in which case we have to perform MRND if there is positive lymph nodes. So ipsilateral MRND when positive lymph nodes are there. So what's the treatment? Total thyroidectomy plus removal of enlarged central lymph nodes plus minus ipsilateral MRND. Ipsilateral MRND is done if any lymph node is positive. Now say follicular carcinoma. It is seen in iodine deficient areas, right? So if patient is staying in iodine deficient areas, there is increased risk of goiter. So indirectly question is asked, what's the most common thyroid malignancy seen in long-standing goiter? Most common thyroid malignancy seen in long-standing goiter, and that is follicular carcinoma, right? It is seen in iodine deficient areas. We discussed it is seen in 5th to 6th decade. Now coming to clinical presentation. So if you see here, the patient is having long-standing goiter. When malignancy is going to develop, patient will come to you and say that, sir, there is sudden increase in the size of swelling. Similar history is there in anaplastic carcinoma thyroid. Sudden increase in the size of swelling. But in patients of follicular carcinoma, there is no pain over the swelling, or there is minimal pain, and there is no evidence of compression. No evidence of compression of midline structures. If you see anaplastic carcinoma here, sudden increase in the size of swelling, severe pain over the swelling with compression of midline structures. So there is dyspnea, dysphagia and hoarseness of voice. These symptoms are not seen in follicular carcinoma. One. Second, very important feature, that lymphatic spread is not seen in follicular carcinoma. If there is no lymphatic spread, it means there is no lymph node metastasis, And if there is no lymph node metastasis in the treatment, what is the treatment of choice? Only total thyroidectomy. We are not supposed to remove any lymph node. So treatment of choice, only total thyroidectomy. No removal of lymph node. If no lymphatic spread is there, what kind of spread is there? There is hematogenous spread. Most common route of spread, hematogenous. And what's the most common site of metastasis? Bones. Most common site of metastasis, bones. Which bone? This question was also asked. It's the thoracic vertebra, followed by ribs, followed by pelvis, followed by skull. It means which bones are involved? Flat bones. Most common site, you have to remember, thoracic vertebra. What kind of secondaries are seen? These secondaries are osteolytic and hypervascular. And if secondaries are osteolytic and hypervascular, these are known as pulsatile secondaries. You know, these pulsatile secondaries are also seen in RCC. So in patients of follicular carcinoma thyroid and RCC, there are pulsatile secondaries. Okay, and these pulsatile secondaries are what first? These are osteolytic and hypervascular. Hypervascular osteolytic secondaries known as pulsatile secondaries seen in follicular carcinoma thyroid and RCC. Coming to the diagnosis, we discussed that FNAC is not going to differentiate follicular adenoma from follicular carcinoma. Why? Because the diagnosis of malignancy is based on capsular invasion or vascular invasion, which is detected only on biopsy. So here, investigation of choice for diagnosis. Okay, this is biopsy. And we already discussed no lymphatic spread, no lymph node involvement. So treatment of choice, it's the total thyroidectomy. Now we are going to discuss medullary carcinoma thyroid. You know, this medullary carcinoma thyroid, it arises from parafollicular C cells. And these parafollicular C cells are derived from ultimobranchial bodies. These are derived from ultimobranchial bodies. Okay, and what's the function? These parafollicular C cells are going to secrete calcitonin. So there is increased calcitonin levels. Okay, increased calcitonin levels are there in medullary carcinoma thyroid. What is the function of calcitonin? It is going to decrease the calcium level. Despite of raised calcitonin levels, the level of calcium is normal. So these patients of medullary carcinoma thyroid are not having hypocalcemia. There is normocalcemia. So you have to remember, despite of raised calcitonin levels, the calcium is normal. Clear? Medullary carcinoma thyroid is of two types. It can be sporadic, it can be familial. Which one is more common? For 80% of cases, sporadic cases are responsible. So sporadic cases responsible for 80% of cases. Familial, these are responsible for 20% of cases. Generally, these familial cases are associated with men or non-men setting. If it is associated with men, which men? It is men 2A, 2B. In men setting, it is associated with men 2A, 2B. And in familial settings, yes, the patient is relatively young. In sporadic cases, it is seen in 6th decade. The nodule, it means the malignancy, is single and unilateral in sporadic cases. But in familial cases, it's multiple and bilateral. So these are the differences between sporadic and familial cases of medullary carcinoma thyroid. See the presentation. There is thyroid malignancy. So patient will come to you with midline swelling in the anterior part of neck. There are certain special features seen in medullary carcinoma thyroid. What are those special features? So we discussed in medullary carcinoma thyroid, there is raised calcitonin with normal calcium levels. These patients have history of diarrhea and there is presence of amyloid stroma. There is positive family history because it is familial. Since there is association with men 2A, 2B, so you might find history of pheochromocytoma or hyperparathyroidism in the family. So there is family history of pheochromocytoma or hyperparathyroidism. Okay, special features. There is another important point, mutation seen in medullary carcinoma thyroid. So doesn't matter whether it is sporadic, whether it's familial, the mutation is common. And what's the name of that mutation? It's RET protoncogene mutation. RET protoncogene mutation. Okay. Another important property. What kind of spread is seen in medullary carcinoma thyroid? So in medullary carcinoma thyroid, we see there is both lymphatic as well as hematogenous spread. Both. What is the most common site of metastasis? It's a bit unusual. It's liver, you have to remember. It is liver. Another important property. Papillary carcinoma thyroid, follicular carcinoma thyroid, they take radioactive iodine because those are well differentiated thyroid cancers. Medullary carcinoma thyroid is TSH independent tumor. Since it is TSH independent tumor, it doesn't take radioactive iodine. And if this tumor doesn't take radioactive iodine ablation is not useful in medullary carcinoma. So another problem, that radioactive iodine ablation is not useful here, and chemotherapy is having limited role in thyroid malignancies and salivary gland tumors. Chemotherapy is having limited role in thyroid malignancies and salivary gland tumor. It means we have only one treatment option left, that is surgery. So we perform extensive surgery in medullary carcinoma thyroid. What is the investigation of choice for diagnosis? So obviously it is FNAC. And see, the treatment is the extensive surgery. So what we do? We perform total thyroidectomy plus routine central lymph node dissection. So we go for routine central lymph node dissection. So it's the total thyroidectomy plus routine central lymph node dissection. And if the size of tumor is more than 1 centimeter, doesn't matter lymph node is involved or not, we go for ipsilateral MRND. If size of tumor is more than 1 centimeter and any lymph node is positive, in those cases bilateral MRND. So this kind of extensive surgery is performed. Why? Because radioactive iodine ablation is not useful. There is very limited role of chemotherapy. Despite of this extensive surgery, prognosis is poor. We discussed that anaplastic carcinoma, it's a rare malignancy, and generally it is seen in which decade? 7th to 8th decade. You have to remember two malignancies which are seen in 7th to 8th decade. One is anaplastic carcinoma thyroid and second is carcinoma prostate. So it is seen in 7th to 8th decade, two malignancies which are seen in 7th to 8th decade, that is anaplastic carcinoma and carcinoma prostate. Okay, we discussed clinical features. So we discussed that there is sudden increase in the size of swelling, there is severe pain over the swelling with evidence of compression. With evidence of compression. So what happens? There is direct invasion of midline structures. So if there is involvement of trachea, what happens? There is dyspnea because of direct invasion. Esophagus, there is dysphagia. And recurrent laryngeal nerve, there is hoarseness of voice. Recurrent laryngeal nerve, there is hoarseness of voice. Why? Because of direct invasion. So here the route of spread is direct invasion. What is the most common site of metastasis? Like papillary carcinoma thyroid, it is lungs. Investigation of choice for diagnosis, obviously it is FNAC. Now coming to the treatment. Two presentations are there. One, if the tumor appears resectable, in that case we go for total thyroidectomy. In certain patients, tumor is unresectable because tumor has invaded or involved the trachea. In this case, life-saving procedure is done, and that's tracheostomy. So what are the treatment options? If tumor is resectable, we go for total thyroidectomy, and if tumor is unresectable, we go for a life-saving procedure, and that is tracheostomy. So this is how we manage anaplastic carcinoma. See the important questions related to thyroidectomy. First question, where will you ligate superior thyroid vessels and where will you ligate inferior thyroid artery? Close to thyroid or away from thyroid? It's written in BD Chaurasia that superior thyroid vessels should be ligated close and inferior thyroid artery should be ligated away. That's wrong. In short, it's clearly mentioned that both superior thyroid vessels as well as inferior thyroid artery should be ligated close to thyroid. Why? Have a look. So first see superior thyroid vessels, both artery and vein, these are ligated separately, and where? These are ligated close to thyroid. Why it should be ligated close to thyroid? To prevent injury of external branch of superior laryngeal nerve. Which nerve? Injury of external branch of superior laryngeal nerve. And this question is indirectly asked. What is the most commonly injured nerve during thyroidectomy? And the most commonly injured nerve during thyroidectomy is external branch of superior laryngeal. In option sometimes it's mentioned external laryngeal. Clear? Now coming to inferior thyroid artery. Inferior thyroid artery is also ligated close to thyroid. It is also ligated close to thyroid. Why? There is parathyroid gland, and if you see this parathyroid gland, it is supplied by parathyroid artery. Okay, this parathyroid artery, it's a branch of inferior thyroid artery and it's an end artery. It's an end artery. So if we are going to ligate inferior thyroid artery away, so what will happen? If it is ligated away, there will be vascular infarction of parathyroid. And because of this vascular infarction, what happens? On 2nd to 5th day, patients are going to notice or develop signs and symptoms of parathyroid insufficiency. So why we ligate inferior thyroid artery close to thyroid? To prevent vascular infarction of parathyroid gland. One question. Second question related to parathyroid gland. Suppose during thyroidectomy you removed parathyroid accidentally, then you had to auto-transplant it. So where we auto-transplant it? In sternocleidomastoid muscle. So during thyroidectomy, accidentally removed, if it is accidentally removed parathyroid, the auto-transplantation is done in which muscle? Sternocleidomastoid muscle. Which part? Belly. So we divide it into 1 mm pieces, going to auto-transplant it in the belly of sternocleidomastoid muscle. Second question. If a patient is having hyperparathyroidism because of parathyroid hyperplasia, in parathyroid hyperplasia all 4 glands are involved. In that case, in parathyroid hyperplasia leading to hyperparathyroidism, we are going to remove 3.5 glands. So 3.5 glands are excised. Only half gland is divided into small pieces, and this is auto-transplanted into brachioradialis. Brachioradialis of non-dominant arm. Generally, the left brachioradialis. So I'm repeating. Accidentally removed parathyroid, auto-transplanted in the belly of sternocleidomastoid. In patients of hyperparathyroidism because of parathyroid hyperplasia, 3.5 glands are removed. Half gland is auto-transplanted into the brachioradialis of non-dominant arm. What are the complications of thyroidectomy? So there can be hemorrhage. What is the cause of hemorrhage? There is bleeding from muscular artery, or sometimes there is slippage of ligature from superior thyroid vessels. So what's the cause? There is bleeding from muscular artery. Okay, and sometimes there is slippage of ligature from superior thyroid vessels. Because of slippage of ligature from superior thyroid vessels, there can be tension hematoma. Why? Because sometimes the drain is blocked. So what is the problem? Sometimes patient is going to develop tension hematoma. So what are the manifestations? In the post-operative period, the patient is going to develop dyspnea or respiratory distress. So whenever we are going to notice dyspnea in the patients, of thyroidectomy in post-operative period, we had to shift the patient to OT, right? What? We had to open the sutures, whatever the hematoma is there, we had to drain the hematoma. You have to control the bleeding, right, by either ligating vessel or by electrocautery, and then after drain insertion, we have to close the wound. So this is how we manage tension hematoma. Second complication is respiratory obstruction. Tension hematoma is not the most common cause of respiratory obstruction. Actually speaking, it's laryngeal edema. Because of intubation and extubation, there is injury. And because of this injury, there is laryngeal edema. So what's the most common cause of respiratory obstruction? It's laryngeal edema. Laryngeal edema. This is the most common cause. Other causes, it can be because of recurrent laryngeal nerve injury. It can be because of tension hematoma. Third complication, nerve injury. Okay, we discussed what's the most commonly injured nerve during thyroidectomy. It is not recurrent laryngeal nerve. It's the external branch of superior laryngeal nerve. So you have to remember, it is external branch of superior laryngeal nerve, also known as external laryngeal nerve. This is most commonly injured nerve. What are the other nerve which can be injured? Recurrent laryngeal and cervical sympathetic trunk, which can lead to Horner syndrome. Fourth complication is parathyroid insufficiency. And we discussed what's the cause of this parathyroid insufficiency. In majority of cases is the vascular infarction. And this vascular infarction leads to parathyroid insufficiency. Manifestation is seen on which day? First question, cause is vascular infarction. And on which day patient is going to manifest? After. So on which day? 2nd to 5th day of surgery. Because of this parathyroid insufficiency, obviously patient will be having signs and symptoms of hypocalcemia. So whenever there are mild signs and symptoms, mild to moderate signs and symptoms, and the calcium level is more than 8, in those cases, how we manage? Oral calcium supplementation. Oral calcium supplementation. If patient is having calcium level more than 8, mild to moderate symptoms are there. Some patients are going to develop severe symptoms or the calcium level is less than 8. In this case, we give IV calcium gluconate. IV calcium gluconate if patient is having severe symptoms or patient calcium level is less than 8. We remove thyroid, so patient is going to develop thyroid insufficiency. And one question which is frequently asked in AIIMS, that what's the cause of thyrotoxic crisis in the patients of thyroid disorders when we perform the surgery? So if you are not going to make patient euthyroid, patient was hypothyroid, there was inadequate preoperative preparation, patient was not made euthyroid, during surgery there is thyrotoxic crisis. So what's the cause of this thyrotoxic crisis? It's because of inadequate preoperative preparation. So it's because of inadequate preoperative preparation. Clear? So these are the complications of thyroid. So these are the complications of thyroidectomy, and this is all about thyroid. Now we are going to discuss parathyroid and adrenal. First we are going to discuss multiple endocrine neoplasia. You know, in all men syndromes, there is one common feature, that all men syndromes are autosomal dominant. Okay. So one by one we are going to discuss. First, we are going to discuss MEN1. So what's the other name of this MEN1? MEN1 is also known as Wermer syndrome. What's the name? It is also known as Wermer syndrome, not Werner. Wermer syndrome, and we discussed all men syndromes are autosomal dominant. MEN1, it is characterized by triad of tumors. So first question, what's the most common endocrine abnormality of MEN1? Most common endocrine abnormality of MEN1, it's the multiglandular parathyroid tumor. First question. Most common endocrine abnormality of MEN1 is the multiglandular parathyroid tumor. Now related question, what is the most common manifestation of MEN1? And the most common manifestation of MEN1 is the obviously hyperparathyroidism. Hyperparathyroidism. This is the most common manifestation of MEN1. What is the most common cause of hyperparathyroidism? It's parathyroid hyperplasia. This is parathyroid hyperplasia. So simple question, in patients of hyperparathyroidism, what is the biochemical abnormality detected? Obviously hypercalcemia. So indirectly the question is asked, first biochemical abnormality detected in patients of MEN1, and that is hypercalcemia. So first biochemical abnormality detected in patients of MEN1 hypercalcemia. So I am repeating three questions. Most common endocrine abnormality of MEN1, that is multiglandular parathyroid tumor. What's the most common manifestation? Hyperparathyroidism. What's the most common cause of hyperparathyroidism? Parathyroid hyperplasia. And the first biochemical abnormality detected, that is hypercalcemia. Okay. Now see the questions related to pancreatic neuroendocrine tumor. First question, that what's the most common pancreatic neuroendocrine tumor seen in MEN1? It is PPOMA, followed by gastrinoma. PPOMA, followed by gastrinoma, followed by insulinoma. Okay, you know PPOMA, that is pancreatic polypeptidoma, it is non-functional. So if the question is twisted and the question is asked most common functional neuroendocrine tumor, most common functional pancreatic neuroendocrine tumor, then it is gastrinoma, followed by insulinoma. If the question is asked most common pancreatic neuroendocrine tumor, PPOMA, gastrinoma, insulinoma, and if it's functional, then it is gastrinoma. How to remember? The mnemonic is PGI. PPOMA, gastrinoma, insulinoma. Okay. There was one question in AIIMS. What was the question? That in MEN1, what is the most common site of gastrinoma? So if you see overall, the most common site of gastrinoma is duodenum. So in MEN1 also, the most common site of gastrinoma, it is duodenum. Okay. Now see the questions related to pituitary tumor. That what is the most common pituitary tumor seen in MEN1? And this is prolactinoma, followed by somatotrophinoma, followed by corticotrophinoma. Prolactinoma, followed by somatotrophinoma, followed by corticotrophinoma. How to remember? Mnemonic is primary sclerosing cholangitis. So answer, prolactinoma, followed by somatotrophinoma, followed by corticotrophinoma. Now coming to the gene mutated. So for MEN1, the MEN1 gene is mutated, and this MEN1 gene, it is located on chromosome number 11. And this MEN1 gene, it is going to encode a tumor suppressor protein. What's the name of that tumor suppressor protein? That is menin. Okay, so you have to remember gene MEN1 located on chromosome number 11 encodes the tumor suppressor protein known as menin. See MEN2. MEN2 is also known as MEN2A and also known as Sippel syndrome. So what are the names? It is also known as MEN2A or Sippel syndrome. Sippel syndrome. What is MEN3? MEN3 is also known as MEN2B. Okay, so MEN2A is actually MEN2 and MEN2B is actually MEN3. What are the similarities between MEN2A and MEN2B? Means MEN2 and MEN3. Similarity that in both there is medullary carcinoma, thyroid and pheochromocytoma. The mutation is same. What? RET oncogene mutation. So see first the characteristic features of MEN2, which is also known as MEN2A. So MEN2A is characterized by medullary carcinoma, thyroid, pheochromocytoma. We discussed it is seen in 2A, MEN2A as well as 2B. Apart from this, there is parathyroid hyperplasia or adenoma. Okay, that is responsible for hyperparathyroidism. There is Hirschsprung's disease and cutaneous lichen amyloidosis. So how to remember? The mnemonic is MP in PHC. It's difficult to find MPs, member of parliaments, in PHC. So mnemonic is MP in PHC. These are the characteristic features. So what's the mutation? Is the RET oncogene mutation, and this RET oncogene, it is located on chromosome number 10. What is the mutated codon? You have to remember the mutated codon is cysteine codon. So in MEN2A or MEN2, the mutated codon is cysteine codon, and if we see MEN2B here, the mutated codon is tyrosine kinase codon. Tyrosine kinase codon in MEN2B, that is also known as MEN3. Now see MEN3, which is also known as MEN2B. What are the characteristic features? So it is characterized by medullary carcinoma thyroid, pheochromocytoma similar to MEN2A. Apart from that, these patients have mucosal neuromas. So here you can see how these mucosal neuromas look like. So you can see presence of mucosal neuromas both in the lips as well as in the tongue. There is megacolon, marfanoid features and intestinal ganglioneuromas. How to remember? Mnemonic is MP had 3 MIs. MP had 3 MIs. Okay. M medullary carcinoma thyroid, P pheochromocytoma 3M, mucosal neuroma, megacolon, marfanoid features, and I intestinal ganglioneuroma. Now coming to the mutations, we discussed like MEN2A, the mutation is RET oncogene, and this RET oncogene mutation, it is located on chromosome number 10. Here, the mutated codon is tyrosine kinase. Mutated codon, that is tyrosine kinase. Okay, so what you have noticed, the patients who are having RET oncogene mutation, they have increased risk of what? Medullary carcinoma thyroid. So the patients who are having this mutation, they are RET mutation carriers, and in these patients we have to go for prophylactic thyroidectomy. Why? Because there is increased risk of medullary carcinoma thyroid. So see the question, what's the age of prophylactic thyroidectomy in RET mutation carriers? In RET mutation carriers, what's the age of prophylactic thyroidectomy? So if patient is having MEN2A, it should be done before 5 years. Before 5 years. And if the patient is having MEN2B, it should be done before 1 year of age. So these are the ages of prophylactic thyroidectomy in RET mutation carriers. Next is MEN4. What is the other name of MEN4? It is MENX. Actually speaking, in MEN4, there are MEN1 associated tumors. In this, there are MEN1 associated tumors with CDNKIB mutation. Which mutation? CDNKIB mutation. Okay, what is the full form of CDNKIB? It is cyclin dependent kinase inhibitor gene. So there is CDNKIB gene mutation, so it is cyclin dependent kinase inhibitor gene mutation. And what is the location of this gene? It is located on chromosome number 12. Okay, so see the characteristic features of MEN4, also known as MENX. The mnemonic is HP target. You can see HP target. H means hyperparathyroidism, P means pancreatic neuroendocrine tumor, T thyroid tumor, A adrenal, R renal, and G is gonadal. G is gonadal. So how to remember? It's the HP target tumor. So these are the special features of MEN1, 2, MEN3, MEN4. If we compare all, first MEN syndromes, if we are going to compare, all MEN syndromes are autosomal dominant. Okay, if you see MEN1, in MEN1 the gene is MEN1 gene, which is going to encode the tumor suppressor protein menin, And what's the location of this gene? Chromosome number 11. If you see MEN2, that is MEN2A, and MEN3, that is MEN2B, here the gene is common, that is Rett oncogene. Yes, and what's the location of this Rett oncogene? Chromosome number 10. If you see MEN4, here the gene is CDNKIB and it is located on chromosome number 12. Here the codon is different. In MEN2A, that is MEN2, the codon was cysteine codon, and in MEN2B, that is MEN3, the mutated codon was tyrosine kinase codon. So these are the important features of MEN syndromes. Now we are going to discuss adrenal incidentalomas. So what are incidentalomas? Incidentally detected adrenal masses. Incidentalomas, incidentally detected, since it is adrenal, so incidentally detected adrenal masses. How we are going to detect these adrenal masses? On radiological investigations performed for some unrelated disease. So these are incidentally detected adrenal masses. Okay, question is asked that what is the most common type of adrenal incidentalo, edit kar dena. So question is asked, what's the most common type of adrenal incidentaloma? It is the non-functioning adenoma. You have to remember, it's the non-functioning adenoma. Okay. Mainly, the questions are asked, since these are incidentally detected adrenal masses, mainly the question is revolving around the conditions in which we are going to perform the surgery. So in incidentalomas, surgery is done if it is hormonally active tumor or the tumor is having high risk of malignancy. And one feature I'm telling you, that if the size of incidentaloma is increasing, it means the risk of malignancy is also increasing. So the risk of malignancy is proportional to size of incidentaloma. See the management. If the size of tumor is more than 5 centimeter, we have to go for surgical removal. Go for surgical removal. If the size is between 3 to 5 centimeter, strongly consider this patient for surgery. So strongly consider surgery. If the size is 3 to 5 centimeter, and whenever the size is less than 3 centimeter, in these cases we go for follow up with CT every 6 months. Follow up with CT every 6 months. In this situation, mainly the question is revolving around what? This. That if the size of tumor is 3 to 5 centimeter, what are the indications of surgery in adrenal incidentalomas? So here you can see that the size of tumor is 3 to 5 centimeter, and in which cases we consider the patient for surgery. If there is suspicious lesion, means you cannot differentiate easily whether this is benign or malignant. Patient is young, means patient can easily tolerate the surgery. If there are few surgical risk, if there is interval tumor growth, and if patient prefers surgery. So in all these cases, we go for surgery. What is the prerequisite? The size of adrenal incidentaloma should be between 3 to 5 centimeter. So this is how we manage patients of adrenal incidentaloma. Now we are going to discuss pheochromocytoma. Very important topic asked in medicine, surgery, pathology, pharmacology, radiology. So you know this pheochromocytoma arises from chromaffin cells of adrenal medulla. Chromaffin cells, and it is generally seen in 4th to 5th decade, equally common in males and females. There is a term known as extraadrenal pheochromocytoma. This extraadrenal pheochromocytoma is also known as paraganglioma. Extraadrenal pheochromocytoma, it is also known as paraganglioma. And what is the question? Most common site of extraadrenal pheochromocytoma, and that's organ of Zuckerkandl. Is the organ of Zuckerkandl. Clear? This is the most common site of extra-adrenal pheochromocytoma. You know that pheochromocytoma is also known as 10% tumor. Why it is known as 10% tumor? Because 10% tumors are malignant, 10% are bilateral, 10% are seen in pediatric population, 10% are familial, 10% are extra-adrenal. Strictly, it's not 10%, but it is known as 10% tumor. You have to remember. What are the syndromes associated with pheochromocytoma? How to remember? You know MBBS. Okay. So how to remember this? MVVS. How to remember MVVS? So M, this is associated with MEN2A, MEN2B. VHL syndrome, von Recklinghausen syndrome, which is also known as neurofibromatosis 1, and S is Sturge-Weber syndrome. So these are the 4 syndromes which are associated with pheochromocytoma. If the question is asked, out of these 4, which one is most commonly associated? So it's the neurofibromatosis 1, which is also known as von Recklinghausen syndrome. This is most commonly associated with pheochromocytoma. Now see the questions related to pathology. Most of pheochromocytomas, these are unilateral and solitary. Unilateral and solitary. We discussed that it is associated with MEN2A, 2B. So if it is associated with MEN syndrome, it's rarely malignant. Pheochromocytomas associated with MEN syndrome, these are rarely malignant. Now see the commonly asked question related to secretions by pheochromocytoma. Pheochromocytoma is going to secrete both adrenaline as well as noradrenaline, but mainly it's the noradrenaline. It secretes both noradrenaline as well as adrenaline. Noradrenaline is more than adrenaline. If you're talking about extra-adrenal pheochromocytoma, it is going to secrete noradrenaline exclusively. Exclusively it is noradrenaline, and in patients of MEN syndrome, pheochromocytoma in men, there is secretion of adrenaline only. It's the adrenaline only. There is one question asked related to malignant pheochromocytoma, that which substance is secreted here. Generally, malignant pheochromocytoma is going to secrete what? Dopamine and homovanillic acid. It's the dopamine and homovanillic acid. How to remember? The mnemonic is MDH. So malignant pheochromocytoma is going to secrete dopamine and homovanillic acid. How to remember? MDH, asli masale sach sach. So MDH, asli masale sach sach. Important features of pheochromocytoma. If you see pheochromocytoma, both benign as well as malignant pheochromocytoma have the property of vascular invasion and capsular invasion. So what's the criteria of malignancy here? In pheochromocytoma, the criteria of malignancy is based on metastasis. The criteria of malignancy in pheochromocytoma, it is based on metastasis. Why? Because both benign and malignant pheochromocytomas are associated with capsular invasion and vascular invasion. See the clinical features. Pheochromocytoma is characterized by a classical triad of headache, diaphoresis and palpitation. What kind of headache is there? There is bounding headache. It's the bounding headache. So the question is asked, what's the most common symptom of pheochromocytoma and most common manifestation? So the most common manifestation is hypertension, and most common symptom is headache. Read the question carefully. Most common symptom, that's headache, and what's the most common manifestation? That is hypertension. Okay, so it is characterized by triad of headache, diaphoresis, palpitation. Now coming to the investigations. What is the most sensitive screening test? And this is the 24 hours urinary catecholamines and VMA level. Most sensitive screening test is the 24 hours urinary catecholamines and VMA levels. Catecholamines and VMA levels. Okay. Now, second question, what is the best test for diagnosis? And the best test for diagnosis is fractionated plasma metanephrines. So this is what you have to remember, fractionated plasma metanephrines. Fractionated plasma metanephrines. Okay. Two questions. After that, question is asked related to radiological investigation. That what is the radiological investigation of choice for adrenal pheochromocytoma, extra-adrenal pheochromocytoma and pheochromocytoma in pregnancy. In all these cases, the radiological investigation of choice is MRI. Okay, so another important question, radiological investigation of choice for adrenal pheo, extra-adrenal pheo and pheochromocytoma in pregnancy, it is MRI. So what is the role of MIBG scan? MIBG scan is helpful for the diagnosis of extra-adrenal pheochromocytoma. But investigation of choice for diagnosis is MRI. I am repeating, MIBG scan is helpful for the diagnosis of extra-adrenal pheochromocytoma, but the investigation of choice is MRI. And there is question which is very important. What's the gold standard investigation for definitive staging? Gold standard investigation for definitive staging of pheochromocytoma, and that's FDG PET. FDG PET. You know that we don't go for FNAC or biopsy in pheochromocytoma. So why FNAC and biopsy is contraindicated in pheochromocytoma? Because if you go for FNAC or biopsy, it can lead to hypertensive crisis. So important question, FNAC and biopsy, these are contraindicated in pheochromocytoma because it can lead to hypertensive crisis. See the treatment aspect. You know that pheochromocytoma is the state of volume depletion. So we have to replace the volume. How we are going to replace? We give crystalloids and we give colloids. We give crystalloids and colloids. You know what is the most common manifestation? Hypertension. Most common symptom, headache. So we have to control the BP pre-operatively. So to control blood pressure pre-operatively, we give alpha blockers. And what's the drug of choice? It is phenoxybenzamine. Phenoxybenzamine. What? To control the blood pressure. And we add beta blockers when tachycardia develops after alpha blockers. So when there is tachycardia after use of alpha blockers, yes, we add beta blockers, right? So this is the medical management. But since it's a tumor, we have to go for what? Surgical management. So what is the treatment of choice for pheochromocytoma? And the treatment of choice is adrenalectomy. It's the adrenalectomy. Okay, so first we prepare the patient. When patient is prepared, we go for adrenalectomy. And if the size of tumor is less than 5 centimeter, it can be performed laparoscopically. So adrenalectomy can be performed laparoscopically if the size of tumor is less than 5 centimeter. So this is how we manage pheochromocytoma. What is neuroblastoma? It arises from neural crest anywhere along the sympathetic chain. What is the most common site? How to remember? Mnemonic is APR. The most common site of neuroblastoma, A is adrenal, P is paravertebral region and R is retroperitoneum. So most common site is the adrenal, followed by paravertebral region, followed by retroperitoneum. You know what is the most common malignancy diagnosed in infants less than 1 year of age? It is neuroblastoma. And neuroblastoma is the most common intra-abdominal malignancy of children? These are the two questions which are frequently asked. Most common tumor diagnosed in infants less than 1 year of age, and this is the most common intra-abdominal malignancy of children. If you see neuroblastoma, there is one unique feature, especially the stage 4S. Neuroblastoma stage 4S, this is having a unique feature of what? Spontaneous regression. It means spontaneous regression is seen in neuroblastoma. Apart from neuroblastoma, what are the other tumors where spontaneous regression is seen? So how to remember? The mnemonic is NCR-MR. Tumors with spontaneous regression. N means neuroblastoma, C choriocarcinoma, R retinoblastoma, M malignant melanoma, R RCC. So these are the 5 tumors where spontaneous regression is seen, and you can remember it by the mnemonic NCR-MR. Now see the presentation. These kids are brought to us with fixed lobular mass. What's the most common presentation? There is fixed lobular mass extending from flank towards midline. So the most common presentation is fixed lobular mass. Okay, and what is the extent? It is extending from flank towards the midline. What is the peak incidence? Generally, the peak incidence is 2nd year of age. So it's a 2 year of age. Most of the patients are brought to us before 4 years of age. In patients of neuroblastoma, there is orbital metastasis. And you focus, because of this orbital metastasis, you can see that there is periorbital ecchymosis. Simultaneously, you can see that there is proptosis. So two findings, there is periorbital ecchymosis plus proptosis. It is because of orbital metastasis, and because of this periorbital ecchymosis and proptosis, what is the name of this appearance? It's known as raccoon eyes. It is known as raccoon eyes. In patients of neuroblastoma, especially stage 4S, there is cutaneous metastasis. Can you see here? This is cutaneous metastasis, and if you see the appearance, it is looking like blueberry. So this cutaneous metastasis is known as blueberry muffin lesions. You have to remember what's the name? It's blueberry muffin lesions. It's because of cutaneous metastasis. Chronic watery diarrhea and opsoclonus myoclonus, these are unusual paraneoplastic manifestations of neuroblastoma. What's the cause of this chronic watery diarrhea? It's because of increased secretion of VIP, vasoactive intestinal polypeptide, and this opsoclonus myoclonus, it is also known as dancing feet, dancing eye. So dancing eye, dancing feet. Clear? You have to remember, this is frequently asked. These are the unusual paraneoplastic manifestations. Now coming to the important questions related to metastasis. At the time of diagnosis, 60 to 70% patients have already metastasis. And generally in older children, what is the most common site of metastasis? It's unusual. It's the long bones. You have to remember, long bones. In infants, the metastasis is seen to liver and subcutaneous tissue. Important feature of neuroblastoma, that lung metastasis is rare. So what are the important features related to metastasis? First, that at the time of diagnosis, already 60 to 70% patients have metastasis. And in older children, what's the most common site of metastasis? You have to remember, it's long bones. Long bones. In infants, the metastasis can occur to liver or subcutaneous tissue. And the question generally asked in exam, that which of the following is a false statement related to neuroblastoma, and the statement mentions most common site of metastasis is lungs. Lung metastasis is rare. You have to remember, lung mets are rare in lung mets are rare in neuroblastoma. On laboratory investigations in neuroblastoma, there is anemia, thrombocytosis, increased LDH, increased ferritin. Apart from this, you have to remember that there is increased urinary catecholamines. These are pointers. Increased urinary catecholamines and increased neuron specific enolase. So there is increased neuron specific enolase. Clear? Increased urinary catecholamines and increased neuron specific enolase. When we perform X-ray or CT, we may find calcification. And what kind of calcification is seen? There is stippled calcification. What kind of calcification? There is stippled calcification. And on IVP, you can see this is the kidney. On IVP, this kind of appearance is there. So what happens? Whenever there is neuroblastoma, it's the mass which is going to displace kidney inferolaterally, and this looks like drooping lily. So on IVP, what's the name of this sign? It's known as drooping lily sign. And we discussed this drooping lily sign is also seen in duplication of ureter with ectopic ureteric orifice. So this is drooping lily sign. In neuroblastoma also, MIBG scan is also helpful in neuroblastoma. What's the use here? Is the single best study to document metastasis. So it is used for documentation of metastasis. MIBG scan. See how we manage neuroblastoma. Common sense question. If it is localized neuroblastoma, obviously we will go for excision. If it is unresectable neuroblastoma, first we go for biopsy. After biopsy, we downstage the tumor. How we downstage the tumor? We give chemotherapy and radiotherapy. And after downstaging the tumor with chemotherapy, radiotherapy, we go for surgical excision. So what we do in unresectable neuroblastoma? Go for biopsy, downstage the tumor with chemotherapy, radiotherapy, and we go for surgical excision. Certain patients at the time of presentation, they have disseminated disease, and in these cases, obviously, we go for chemotherapy. So this is how we manage. There is another term which is frequently asked, esthesioneuroblastoma. It is also known as olfactory neuroblastoma. So why it is known as olfactory neuroblastoma? Because it arises from basal neural cells of olfactory mucosa. Basal neural cells of olfactory mucosa. So it is esthesioneuroblastoma, also known as olfactory neuroblastoma. So this is all about parathyroid and adrenal.